Everyone. It gives me immense pleasure to welcome you all to this exciting Fever Foundation quiz. As you all know, it's the first ever quiz on fever. It's all related to fever and related condition. And thanks for registering and joining in. So before we go ahead with the quiz itself, I would like to again reiterate the rules of the games. Some of the rules have been sent to you, but I'm going to repeat them so that you'll be very clear when you're playing the game. The rules are the quiz is for postgraduate student only. You have to be PG student to play this game. And the quiz consists of multiple choice questions. The option to be selected by the clicking the button on the text panel. So you have a text panel on the right hand side. You need to click the text button. The video that is being displayed is only for representation purpose. You cannot click on the video. So you please click on the text on the panel which you have text panel next to you on the video. The participants are advised not to leave the platform and enter the YouTube channel. YouTube is only for viewing. You cannot play the game. You cannot play the quiz there. So therefore, please stay on for all the 20 questions on this platform to answer the quiz and to participate in the quiz. So once you submit the answer, it will not be possible to reverse it. There is no negative marking in the quiz. The winner will be maximum fast right answer. Who is the fastest, but he has to give the right answer. Who gives such maximum responses will be the winner. In the event if there is a tiebreaker round of 3 questions will be done. To answer the quiz then it will be done to decide the winner. And it is advisable to use the laptop and desktop for the better experience of this game. Next slide. So therefore, we request you to advise to participate from a place you have a good internet connectivity as it is being an online quiz. And if found to be any type of foul play, your candidature or your registration will be automatically disqualified. And you should not use mobile phone for getting answers from any of your colleagues sitting nearby. Fever Foundation is not responsible for any form of technical error such as poor internet connectivity, etc. Participation in the quiz implies that participant accept the integrity of these rules. The participants who have given incomplete or inaccurate personal contact details will be disqualified. Non-compliance with the rules of the game results in automatic cancellation of the participant in the quiz and the candidacy for the prize. And please note that first and second winner will be play from each of these zones. For example, you are playing the North Zone. So first and second winner of this this quiz will enter the national level quiz, which will be held in Bangalore on November 5th and 6th, FEFCON 2022. So you will be playing as a team. Right now you are playing as an individual candidature, but at the national level, both of you will become a team, first and second winner, and you will play as a North Zone representative. So finally, the quiz master and the judge's decision will be final, and all of us have to bind by the decision given by them. So I wish you all the best for the quiz. And I would also like to introduce our eminent judges and the quiz masters who are here. So our first quiz master is Dr. Rashna Hazarika ma'am. She is MBBS and MD Pediatrics from PGI Chandigarh. And she is trained in pediatric emergency and intensive care at PGI Chandigarh for more than a year. And her areas of interest include pediatric intensive care emergency, pediatric infectious and respiratory disease, and pediatric rheumatology. There are several achievements, awards, and accolades. To name a few, she established the Department of Pediatrics at NEI GRA HMS at Shillong in 2005 and designed and supervised the whole construction of the first pediatric ICU in the government hospital in northeast of India and made it functional in 2007. And he helped in distinguishing, designing the MBBS syllabus for the same institution in 2008. She has several publications to her credit, more than 50 page publications in various international, national, and regional index journal, such as PubMed, Biomed Central, and she has written several chapters in books. And she's been a researcher. She has conducted a number of multiple projects, multi-centric projects under Indian Council of Medical Research, that is ICMR, and International Clinical Epidemiology Network. Other administrative responsibilities she has held and she's holding are editor of IAP Meghalaya, secretary IAP Guwahati, secretary IAP Assam, and she's the editor of Breeze, the newsletter of IAP Guwahati, and chairperson of scientific committee of East Zone Academy of Pediatrics. And she's been the member of task force of Government of India on COVID-19 preparedness for children. Ma'am, Dr. Rachna ma'am, it's a pleasure and privilege to have you with us as a judge. Welcome to you, ma'am. Our second judge is Dr. Anand Vasudev, sir. Sir is DNB and Pediatrics, DCP, and he has done FIAP, MNAMS, FIMSA, MICP, USA. He's a senior consultant pediatric nephrologist at Indraprastha Apollo Max Hospital, Holy Family Hospital, New Delhi. He's been the national vice president of IAP 2020. He's been a vice chair of Pediatric Kidney Foundation. He's a visiting faculty at MCW USA, editor-in-chief of IAP textbook of pediatric nephrology, editor of algorithms in pediatrics, editor of IAP textbook of radiology. He has been awarded several awards and accolades. Some of the few of them are V. Balagopal Award of IAP Best Paper, Sarla Vaishnav Award of IAP Delhi Best Paper, Young Scientist Award of Department of Science and Technology, Puneet Sharma Oration Award in 2020, Dr. Gopal Sharma Oration at Bihar Pedicon in 2019, over more 50 publications in national and the international index journals, large number of chapters he has written in several books, and he has delivered more than 500 talks in both national and international conferences. Dr. Anand Vasudev, sir, it's a privilege to have you with us, sir. Welcome to the quiz program. So I wish you all the participants best of luck. Now I hand over the session to our quiz master, Dr. Rachna ma'am and Dr. Vasudev, sir. Sir, over to you, sir.
Thank you. Thank you very much for your kind introduction. And first of all, thanks to the Microlab for organizing such a wonderful quiz session for the postgraduates. Not only a learning exercise for the postgraduates, but also for the quiz masters, because there are a few things which we also had to look up into the text, but that was a pleasure. And with that, the other co-host in the quiz would be along with me, Dr. Rachna Das Hazarika from Guwahati, and it will be a pleasure for both of us to take you through these 20 questions in the quiz. And wishing you all the best to all the participants, and do your best. And one thing I want to say that this is like a quiz and it's not your exam. So don't get hassled, don't be very tense, and don't be very purpose about it. Just play it like a quiz and try to answer as much as you can without any fear. There is no negative marking, so you won't lose anything. But again, as already told by Dr. Manjula, that you have to be very quick, fast, and your acumen in the subject along with your speed, both these things matter. Of course, luck sometimes would also play a role in it. With that, I think, Dr. Manjula, we can start the quiz.
Sir, you have for them to become familiar, can you play some 3 dummy questions so that they become familiar with the platform? No marks will be allotted to this. Madam, you can.
Dr. Rachna, Dr. Rachna, would you like to convey some message to our youngsters who are on the platform?
I think, all the best. I really enjoyed the Eastern Zone quiz, and I'm sure we're going to have a fantastic evening today. And I think without wasting much time, we should start first with a dummy question, sir, because so that they get used to the pattern. And it's over to you, sir. Vasudev, sir.
Yeah. So, Dr. Krishna, can you, the IT team, who will be projecting the IT team?
Yes, sir. Computer G.
Computer G will be projecting. So, we request the Computer G to start the quiz, and with a bang, wishing everyone good luck, and we can start. Now, coming to the first question, these are all general questions just to apprise you about the pattern and also test your internet connections and your laptops and your skills, and also training your fingers in pressing the buttons as quickly as they can. So the first question comes as, which film in India's official entry for 95th Oscars? Answers are Kashmir Files A, B is Chhelo Divas, C is Chhelo Show, and D is Triple R. So your time starts now. Right. So computer ji, let us know what is the correct answer. Chhelo Show is the correct answer. So let us see how many of the participants had the correct answer, number of movies, and how many of them are really fond of movies and really fond of the current affairs. So let's see the results.
So have you heard of this movie?
No, I haven't seen this movie.
I have heard of Kashmir Files and RRR, but the other two, I mean, obviously, I have not heard.
Yeah.
Oh,
Right.
interesting.
Interesting. So I think there's a division of answers, and nobody was really sure of the correct answer. So it's been a mixed response. Anyway, doesn't matter. These were new movies to us also. So must have been new to many youngsters. So thank you. And computer
So
ji, can we?
actually, I think these PGs don't get time to see movies because of duty.
I doubt that, because in our PG days also, I remember that we used to run for the night shows whenever we were free, or the midday shows, I'm sure. So nice. And computer ji, can we go on to the second question? The round of practice round of the quiz, or second question. Here comes the second question for you. Question is, who is the current Chief Justice of India? Choices are A, Uday Umesh Lalit, B, Mr. Ranjan Gogoi, C, Sharad Arvind Bobde, D, Nathalapati Venkata Ramana. So these are four answers. So your time starts now. Right. Thank you, computer ji. And let's see the results. How many of them are actually into the current affairs and know about our Chief Justice of India? Right. The correct answer is Uday Umesh Lalit. And I think I feel that everyone of us should know that all these prime positions which are in the country, like Chief Justice is one of the very prime positions, like our Prime Minister, President, Chief Justice of India, and we all should be knowing who exactly is holding the topmost post in the Supreme Court. So it's Mr. Uday Umesh Lalit. And let's see the results now. Oh, not very encouraging. So only 21% have given the correct answer, and majority have given about the just retired Chief Justice of India. But again, as Dr. Rachna ma'am said, that most of our PGs are busy in their books and duties, but never mind. So these are only trial questions, and we can go on to the next third question. The third and the last trial question is newly appointed trustee of Prime Minister CARES Fund? Who is the newly appointed trustee of the Prime Minister CARES Fund? And your answers are A. Gautam Adani, B. Ratan Tata, C. Mukesh Ambani, D. Azim Premji. And your time starts now. Computer ji, please log the correct answer. Right, the correct answer is Mr. Ratan Tata. So he's a man of great repute. We all know him for all his philanthropic work in the country, and a man of great stature in our country. So let us see the results. How many of our youngsters voted for Mr. Ratan Tata?
Actually, there are three people. There are three people who are chairpersons, and one of them is Ratan Tata. So I think majority have got it right this time.
Yeah. So I think he's been a popular figure, and 61% is a good number. I think that's the trial questions we've had. So I'm sure now all the PG's youngsters would be ready for the actual quiz, and we can start the actual quiz, and you would have all geared up with the trial rounds. So Computer ji, are we ready with the actual quiz, and can we start the questions? Question number 1, we can go ahead with question number 1, Computer ji. Right. So question number 1 comes as hyperthermia is defined as a temperature more than. Please note the question. Hyperthermia is defined as a temperature more than. Answers are A, 40.5 degrees Celsius, B, 41.5 degrees Celsius, C, 42.5 degrees Celsius, and D, 43.5 degrees Celsius. And your time starts now. Right. Thank you, Computer ji. Let us log the correct answer. Right. The correct answer is B, 41.5 degrees Celsius, which is equivalent to 106.7 degrees Fahrenheit. And let us see the results. How many of our youngsters voted for the correct answer? And in the meantime, while the computer is analyzing the results, we would just like to reinstate that the temperature control is done by the hypothalamic center, which has got a heat regulatory set point, and the hypothalamus would control if it is an euthermic condition. The heat set point is there, and the body temperature tries to reach that heat set point, and the temperature would be idealized, that is the euthermia. When there is fever, the set points gets elevated in the hypothalamus, and the body tries to reach that temperature, and the temperature in the body rises and one gets fever. But when there is a heat stroke, the hypothalamic set point remains where it is, but the body temperature rises. So that is the difference when there is fever and when there is a heat stroke. And that's important because the management also is very different. While we would bring down the temperature when there is fever by giving paracetamol or other agents and by sponging, tepid sponging or cooling. But if it's a heat stroke, then these medications would not work. And we just have to cool the environment and cool the body temperature, and the air has to be cooler, and by sponging, we have to bring down the temperature. Dr. Rachna, anything you would like to add on this question?
You've already covered most of it. Here, we have to understand that it could be an exogenous cause or an endogenous cause. So in India, the most common exogenous cause is the hot climate during the summers, and that's why we have so many people who have heat stroke and they die. In the exogenous causes, the most important ones are the medications like the anesthetic agents which are used, and they have what is known as malignant hyperthermia. Then some of the endocrine causes like thyrotoxicosis and pheochromocytoma can also lead to hyperthermia. So main thing is that you have to recognize these patients where the skin is very hot and dry, and usually if you don't treat them, then it becomes fatal.
Right, thank you. And Computer Ji, if you're ready with the answers, let us see the correct answers. How many of our youngsters have given the correct answers, and who is the fastest finger? Right. So we have the correct answers being given by 53.8%. And who is the fastest finger? Let us see the response. Dr. Nikita Singh, congratulations. She has taken to answer the question in 4 seconds. Excellent. Congratulations, Dr. Nitika, and keep it up. 4 seconds is really a short time to answer the questions. Congratulations. Thank you, Computer Ji. We can go on to the next question. Right, the next question comes for you. The next question is, rectal measurement of temperature is the gold standard, but it cannot be measured in. Choices are A, thrombocytopenia, B, neutropenia, C, coagulation disorders, and D, abnormal liver function tests. And your time starts now. Thank you, Computer Ji. Let's lock the answer, which is the correct answer. Neutropenia. Neutropenia is the correct answer. So rectal temperature, as we all know, is the gold standard, and it reflects the temperature of rectal arteries. And we normally use it in pediatric population, in newborns also. And being the gold standard, it's very good, especially in measuring the hypothermia. The disadvantages sometimes with measuring the rectal temperature can be that the child may experience pain, there may be sometimes abrasion, and sometimes there's a psychological disturbance, and the children don't like to get the thermometer inserted in their anal area. So that can be a psychological problem, even with older children especially. Perforation is one thing which is actually very rare, and one should not worry about the perforation. It is 1 in a million cases, and we have hardly seen any child having perforation with measuring the rectal temperature. Dr. Rachna, would you like to add anything more to the rectal temperature?
Yeah, the only reason we don't want to do it in neutropenic patients is because, they would expose them to infections, which can be picked up when you insert maybe an unclean or not properly cleaned thermometer. So though this is the gold standard of measurement, but it is very difficult to use rectal thermometers in clinical practice. And that is the reason why we go for auxiliary temperature measurement. But if you have to do research, then yes, rectal temperature is the gold standard. And everything is, this is taken as a standard for comparison of data. And one has to remember that the rectal temperature is 0.4 degrees more than the axillary temperature. So that has to be kept in mind.
Yeah, we use using rectal temperature, especially in nurseries and in NICU, where the newborns are there, and it's very difficult to take the axillary temperature. So rectal temperature is comparatively easier to take. Thank you, Dr. Rachna. I think we can, if the Computer Ji is ready, we can see the percentage of members voting for neutropenia, choice B. Oh, choice B has been answered by very, very few, only 10%. So I think most of the people would have gone for other answers. And Dr. Sunidhi Singh has given the answer in 7 seconds. Congratulations, Dr. Sunidhi, keep it up. And this is only the second question. So you have 18 more rounds, and we expect you to answer more questions more rapidly. Thank you. Thank you, computer.
I think Dr. Vasudev, this was a very, very important learning question for the participants, where, you know, they have to remember that in neutropenic patients, in those patients with neutropenic fever, you're not going to do a rectal thermometry.
I think most of them who answered more were thrombocytopenia, probably worrying that it might cause some bleeding. But actually, as Dr. Rachna said, it's more related to our worry about the infection being introduced in a neutropenic patient rather than bleeding. And as I said, that injuries are very, very rare with measuring the rectal temperature. Thank you, Computer Ji. I think we can go on to the third question. Here comes the third question for you. The question is, which of the following statements are false regarding pyrexia? The answers are: A, pyrexia is persistence of fever more than 38.3 degrees centigrade. B, pyrexia is persistence of fever more than 37.3 degrees centigrade. C, pyrexia may be caused due to infections, malignancies, and drugs. And D, both A and C. So please note the question very carefully. It says, which of the following statements are false regarding pyrexia? So you have to pick up the false statement, and your time starts now. Thank you, Computer Ji. Let's see which is the correct answer. Let's log the correct answer. Answer B is the correct answer. Pyrexia is persistence of fever more than 37.3 degrees centigrade. And this is equivalent to about 99.1 degree Fahrenheit. And again, anything would you like to talk about pyrexia, persistent pyrexia, Dr. Rachna?
Actually, here the choice is quite evident, because when we say 37.3, we know this is normal temperature. Basically, especially in neonates, we say that 36.5 to 37.4. 37.4 is a normal temperature. So this will be a normal temperature. And in neonates, we say that if it is more than 37.4, then only we consider it to be a hypothermia. And fever per definition is 38.3 degrees centigrade, which is about 101 degrees Fahrenheit. So knowing these very small differences in calculation of the defining fever is very important for clinical practice. Because many a times we get calls from parents, you know, I have a child who is having fever and the temperature is 98.6. So usually they will tell you 98.6, and you already, before you can say that this is normal, they would have already given paracetamol or, you know, even some other anti-inflammatory agents. So educating parents also about what is fever is quite important, and what is the time when you will give an antipyretic agent is also important. So at 37.5, 38 also we may not use antipyretic unless the child is uncomfortable. So by definition, if it is more than 38.3 or more than 101, then we will give some paracetamol and just to make the child comfortable. We do not want to bring it down to 98.4.
Right. So here what we wanted to highlight was, So the correct answer has been given by 75%, which is again, this was the correct answer?
Yes, this was the correct answer.
Correct answer, yeah, B.
All of them are aware.
Aware of, yeah.
Very good.
So I think that's good that what we wanted to highlight has been picked up by majority of the candidates. And Dr. Kunal Kashi is the winner of this. How many seconds he has taken, Dr. Kunal? And Kunal is probably a boy. Yeah, Kunal is boy. 4 seconds he has taken to answer the question. Very nice. I think most of the youngsters are aware of what is actually not fever, and they should not let the parents worry about that temperature of 37.3 degrees or 99.1 degree Fahrenheit as the fever. So they should be aware about it. Thank you very much. Computer ji, we can go on to the 4th question. Right. The 4th question comes here. This is about the hereditary periodic fevers. And we would like to ask you, hereditary periodic fevers are autoinflammatory disorders characterized by the following, except. Again, please note the question that the following are present, except. Answers are genetic basis. B, may be complicated by amyloidosis. C, may result in malignancy. And D, usually multi-systems with elevation in inflammatory markers. And your time starts now. Right, thank you. And let us see the correct answer, Computer ji. Right, so answer C is the correct answer, that all these are present except that the periodic fevers, hereditary periodic fevers may result in malignancy. They normally would not result in malignancy. And these hereditary periodic fevers are recurrent episodes of fever, and they are autosomal recessive. Mode of inheritance is normally seen in them. And many of these would have pleural and peritoneal inflammation, resulting into sometimes having arthritis, rash, and these are autoinflammatory diseases. Basically, some of these are like familial Mediterranean fever, hyperimmunoglobulinemia D, and they are usually having recurrent fevers, but they do not result in malignancy. So they have genetic basis, may be complicated by amyloidosis, and as already said, multi-system with inflammatory markers also. Dr. Rachna, anything to add in this?
I think you've covered most of the points. Since it is a multi-system inflammatory disorder, so they have involvement of many organs, including the eye and the bones. So some of them may have, they have increased risk for osteoporosis. And actually there is a defect in the innate immunity, and therefore they are more prone to infections also. And usually there is a defect in the IL-1.
What is the taxi bill, FPA doctors and all that? What is that? Can you please explain to me?
Which one?
Mr. Jairaj, you are asking something? Mr. Jairaj is...
No, he has to be under mute. Can you mute him, please?
Yeah, what is that bill for?
No, Mr. Jairaj, can you mute yourself? Mr. Jairaj.
Okay.
IT people, can you mute Mr. Jairaj?
For which we gave
Mr. Jairaj, sir, can you mute yourself? Jairaj, Mr. Jairaj, please mute yourself.
Abira, please walk up to them. Yeah, walk up to sir now.
It's done, no issues.
Okay,
Thank
and
you.
most of these, we would have to use an anti-inflammatory like an IL-1 blocker. So then only they will respond. So they may not respond to usual treatment of fever.
Right. Thank you. And Computer ji, if you are ready with the results, let's see. C, 52.63% have given answers. So almost half of you are correct. But I think all the youngsters, I would recommend that you should learn about these uncommon conditions, which are very important for your post-graduations and for your examination point of view. You do see all these infective causes of fever, but these uncommon hereditary periodic fevers and other uncommon conditions, I think you should look into them also, and they are from exam point of view so quite important. So let's see the who has given the correct answer. Dr. Radhesham, congratulations, Dr. Radhesham. You have given the correct answers and the time you have given is 7 seconds. Not very bad. So you try for more questions. We still have a lot of questions to go ahead. Thank you. Thank you, Computer Ji. Can we go on to the next question? Right, we come to the next question. And the question says, what is Mollaret's meningitis? Answers to this are A, recurrent episodes of meningismus, B, chronic recurrent episodes of headache, stiffness, stiff neck and fever, C, cerebrospinal fluid pleocytosis, D, all of the above. And your time starts now. Right. Thank you, Computer Ji. Let's log the correct answer. All of the above. So all these signs of meningismus, CSF changes, recurrent episodes of headache, stiff neck, fever, all these are the symptoms and signs of the Mollaret's meningitis. Dr. Rachna, would you like to tell something more about the Mollaret's meningitis?
It's actually a form of an aseptic meningitis. So there are many conditions which cause aseptic meningitis, like say mumps or measles. You can also get aseptic meningitis. In pediatrics, the most common is mumps, which causes aseptic meningitis. But here, you know, you will not find an organism. Whatever test you do, you will not get an organism. So till now, nobody has known what is the exact cause of a person having these recurrent episodes of aseptic meningitis. Probably there would be some immunological etiology, but we have not till now got the exact pathogenesis or the pathophysiology being described. It was first described by Pierre Mollaret in about 1944. And the description is that the first in the CSF, you get mononuclear cells. So these mononuclear cells were known as Mollaret's cells. And after 24 hours of infection, actually the mononuclear cells convert to lymphocytes. So in the CSF, you will usually get a lymphocytic predominance, but all the others like the Gram stain, the other markers of infection, all these will be negative. So quite uncommon, but I think if you have a person who's coming with repeated episodes of aseptic meningitis, this is something which we must keep in mind.
Right. Thank you, Dr. Rachna. Computer Ji, if you're ready with the result, let's see how many I have given D as the correct answer.
And actually, you don't need to treat this. It resolves by itself.
Oh, great.
Wow.
89% have given correct answer. D is correct answer. And good that I think large majority, almost 90% know about Mollaret's meningitis as such. But this condition, as I was telling you, Dr. Rachna, has not been mentioned by this name in Nelson's textbook. Probably our youngsters are reading other textbooks also other than Nelson to find this Mollaret's. Internet, right. Right, great. And let's see who is the fastest finger in the correct answer. Nitika Singh, right. Nitika Singh again, congratulations. Taken 5 seconds. I think she is doing a great job and not only being knowledgeable, but also being fast and quick. Congratulations, Nitika. Keep it up. Thank you, Computer Ji. We can go to question number 6. Right. Now, question number 6 comes with a visual round. And I think most of our postgraduates would be very well aware about this condition. This is a sandpaper rash is seen in this picture. And what is the cause? Is it urticaria? Choice A, urticaria. B, rickettsial fever. C, scarlet fever. D, impetigo. So it's not very difficult. And most of them would be able to answer it very correctly. Can we start the round? Your time starts now. Right. Computer Ji, can you log the correct answer? Scarlet fever, right. And again, it's not very difficult. In scarlet fever, once the fever comes and goes down, there's a sandpaper rash, which may appear on the neck and on the upper part of body, sometimes on the arms also. And it's very classical. Once you have seen it, I don't think you will ever forget. And urticaria, again, is a very common condition which most of us see as hives. These are red patches, normally very itchy. In rickettsial fever, again, there's a palpable purpuric rash, along with the platelet count is classically decreased in rickettsial fever. There's usually hyponatremia. The enzymes in liver enzymes, as the OTPT, are normally raised, and there's clubbing of platelet, which leads to a pseudo decrease in the number of platelets. The platelets may actually not be very low, but there is clubbing leading to a pseudo impression that the platelets are low. And again, rickettsial fever is caused by fleas, mites, lice, ticks, and a classical HR sometimes may be seen. And impetigo, of course, we all see day in and day out in our clinical practice with the multiple pustules and children coming, especially in summer and rainy season. So the correct answer is scarlet fever. And so I think this was C, 100%.
Yes.
Oh, that's great.
Excellent.
I think, as I said, that the guess was that by just looking at the picture, almost every one of our post-graduation should be able to give this answer correctly. And I don't think there's anything else to be told about scarlet fever. I think it's quite common entity, and they can all recognize it.
It's just because of an exotoxin that you get these appearance of the rash in that particular pattern. So sandpaper means it looks rough, as you would have noticed from the picture.
Right. So I would like Sahil Mittal. Sahil Mittal has given the correct answers in 4 seconds. Expected even a shorter time would have been good enough, but 4 seconds again is a very nice short time. Congratulations, Sahil. Keep it up, and we ask you to answer more questions in the future rounds. Computer Ji, can we go on to the round 7? 7th question. Here comes question 7 for you. The question is, what are the features of congenital varicella syndrome? The answers are A, cicatricial scarring of the limbs. Answer B, skin involvement in dermatomal pattern. The answer C is a digital defect, and answer D, all of the above. And your time starts now. Thank you. And Computer Ji, let's log the correct answer. All of the above, right? Answer D is correct. All the above are seen. And Dr. Rachna, would you like to say something on the congenital varicella syndrome? We have already told about the features here and a little more about it.
It's a very rare condition, and usually the manifestations, the severity of the manifestations will occur if the mother gets infected during less than 20 weeks of pregnancy. So the more the infection is towards the organogenesis time, the more will be the effect on the various organs. So that's why you see you get digital defects, then scarring of the limbs and skin involvement. And they can vary from, again, person to person. So it is not that all patients will have all findings. So usually the earlier the infection, the more worse will be the presentation.
Right. So we have answer D as the correct answer. And Computer Ji, can we see how many? Oh, great. 89. Again, 90% have given a correct answer, that all the above features. So I think youngsters have read well, though may not have seen the condition clinically, but at least they know all the features of the congenital varicella syndrome. And who is the fastest finger among these 90% correct answer? Kunal Kashi. Kunal Kashi again. I think Kunal had answered the question earlier also. He's again taken 4 seconds. Congratulations, Kunal. Keep it up and answer more questions so that you can be one of the winners. Congratulations again. Thank you, Computer Ji. And we can go on to question number 8. Question number 8 comes to you, youngsters. PGs, be ready. The question is, recurrent fever with abscesses is seen in which condition? The answers are A, hyper IgM syndrome, B, chronic granulomatous disease, C, SCID, D, agammaglobulinemia. And your time starts now. Thank you, Computer Ji, and let's log the correct answer. Correct answer is CGD, chronic granulomatous disease. I think this is one of the diseases where there are recurrent fevers with abscesses, recurrent infections, and this is hyper IgM syndrome. IgM levels are increased. There's low or absent IgA, IgG, and IgE, and there are recurrent pyogenic infections. While the SCID is a severe combined immune deficiency, and again SCID usually occurs with a lot of infections in infancy, with the ear infections, interstitial lung disease, sometimes chronic diarrhea, failure to thrive, and oral thrush, which is difficult to treat. And again, agammaglobulinemia. So all these conditions are the ones which give rise to recurrent fevers and recurrent infections. And I would just ask Dr. Rachna if she needs to add anything more.
I think in CGD, the students have to understand that it's a defect in the NADPH oxidase enzyme. And therefore, the phagocytes are not able to kill the bacteria or the fungus. And that's why you land up with these deep-seated abscesses. The treatment here, the curative treatment is bone marrow transplant. Earlier times when we did not know that bone marrow transplant was cured, we used to keep these patients on chemoprophylaxis with an anti-staphylococcal agent and an antifungal agent. But now we know that BMT is the treatment of choice, and there are lots of success stories from India only for various BMT centers where such primary immune deficiency disorders children have undergone BMT and they're leading a normal life. In the previous one, we had asked one question where we said, you know, malignancy is a cause, but here you have to understand hyper IgM is the one where the patients are prone to get malignancy. Oh, answers are very interesting, sir.
Oh, almost 25% of each of these answers. So I think there's a lot of confusion and not very much of clarity about the chronic granulomatous disease. And I think the students are answering all these SCID as well as the hyper IgM syndrome and agammaglobulinemia almost equal. Again, CGD again would show a lot of leukocytosis and thrombocytosis as already pointed out, and the treatment has also been, I think again, I would request the youngsters to go into these uncommon conditions also, along with the other routine infectious diseases for fevers and the recurrent infections being seen in the childhood. So let's see who is the... So Safia Soda has given the correct answer, and she has given it in 7 seconds. Not bad, because this was a difficult question and not many of you could answer correctly. But Safia, congratulations and keep it up. Thank you. Thank you, Computer Ji. We can go on to question number 9. Here comes question 9. The question is perceptual distortions of the size, shapes, and spatial relationships seen with the Epstein-Barr virus infectious mononucleosis is called A. Alice in Wonderland syndrome, B. Todd's syndrome, C. Dysmetropia, D. All of the above. And your time starts now. Thank you, Computer Ji. Let's log the correct answer. Correct answer is all of the above. Answer D is the correct answer. And I'm sure many of the youngsters would have heard about the Alice in Wonder syndrome and EB virus infections. The EBV infections are normally, they present with the fever, sore throat, and sometimes malaise, generalized lymphadenopathy. The lymph nodes are enlarged, and that's why sometimes it's also called as glandular fever. And there are atypical lymphocytes, and hepatosplenomegaly normally is the one of the signs which is present. And in this, there is a strangely distortion of body or visual images of size and shape. And that is why the word Alice in Wonderland has been given. And anything more would you like to add about the EBV infectious mononucleosis, Dr. Hazarika?
I think you covered for EBV, but I think what we should understand is that most of these distortions of size, shape, and usually occur more at night. So, you know, the small things would be seen as big, or the big things would be seen as small or crooked that way. And the Todd syndrome is the one which is associated with migraine. So usually this is said to be very classical of migraine, that, you know, when you have severe migraine, then you have distortion in the image which is seen. And most of it's supposed to be the trademark syndrome in migraine. And this is usually treated with migraine prophylaxis in those who have migraine. In others, I think in Alice in Wonderland, in EBV and all would be just symptomatic management. You would not do anything as such. The exact mechanism for this is also not known. How this occurs and why it occurs, it has still not been discovered. So the only one which we can treat here is the Todd syndrome related to the migraine prophylaxis. So we can give anti-migraine drugs for these patients.
Right. I don't think for Alice in Wonderland type of symptoms which would come and disappear. There's anything much which we can do. Right. Computer Ji, can you show us the percentage of students who have given correct answer? D, 65%. Great. I think most of you have read about the EBV infectious mononucleosis, and you have given the correct answer. And who is the fastest finger? Akriti Kumar. Akriti Kumar, okay, a new entrant. She has answered in 6 seconds. Congratulations, Akriti. Keep it up and try to answer more and more questions. Thank you. Thank you, Computer Ji. We can go on to the 10th question. Right, here comes the 10th question. We are almost midway through. And the 10th question says, most common cause of occult bacteremia, fever without focus in a child 3 to 6 months of age. The answers choices are A, Streptococcus pneumoniae, B, E. coli, C, Klebsiella, D, Enterobacter. And your time starts now. Thank you, Computer Ji. Can we lock the correct answer? Right. So the correct answer is Streptococcus pneumoniae and answer A. So Dr. Hazarika, would you like to say something about this particular occult bacteremia caused by the Streptococcus pneumoniae?
Yeah, so the catch in the question was 36 months. So because below 3 months, the organisms, as we know, would be different. Initially, before the vaccination era, when we did not use universal vaccination with the pneumococcus vaccine, this organism, Streptococcus pneumoniae, was supposed to be the most common cause of occult bacteremia. Why occult bacteremia? Because these children would not have a focus. They would actually have a septicemia because of the Streptococcus pneumoniae in the system. And you would not be able to, pinpoint a particular organ system which is involved. And 80% of these would be because of Streptococcus pneumoniae. The rest 10% would be because of H flu. And another 5% would be because of Neisseria meningitis. But now I think if we do a research again on this occult bacteremia in the era of universal H flu, Haemophilus influenzae, and Streptococcal pneumococcus vaccine, I think this data will change. So, but to remember, even now in our country, I think this is important to remember because there are many places we are still not giving pneumococcal vaccine. So this is the number one cause that we should have in mind. And most of the time, if you're lucky, you can culture it if you take a blood culture before giving the antibiotic.
Right. Thank you. Thank you, Dr. Rachna. And Computer Ji, can we see how many have answered A? Again, little divided. So there was some confusion between the bacteria. So answer A is given by 32%.
Actually, they thought of E. coli,
E. coli,
and gram-negative and all because of but the catch was the age. So above 3 months, it is mostly the gram-positive bacteria.
Right. So 32%, and Amit Mathur has given the correct answers. Correct answer in 5 seconds. Congratulations, Amit. You are the new entrant, so keep it up and try to answer more questions so that you come to as a winner. Thank you, Amit, and congratulations. Thank you, Computer Ji. I would now request Dr. Rachna to kindly continue with the remaining 10 questions. And Computer Ji, can you give the next question? And Dr. Rachna, kindly please take over for the next question.
Thank you, sir. Very well done till now. Let's go to question number 11. Splenomegaly and splenic rupture is a complication of which infection? Adenovirus, dengue, EBV, or all of the above? Your time starts now. So let us look at what is the correct answer. So Epstein-Barr virus. Usually, this is a virus which causes multi-system involvement with, especially in adolescents. And so it is also known as the kissing disease because, it spreads from one person to another by very close contact. And most of these patients, if they have chronic EBV, they will have a lot of fatigue. It takes a lot of time to recover from the infection. And how do we recognize it? We recognize it mostly as a fever with lymphadenopathy, cervical lymphadenopathy, and small splenomegaly. But the point here is that, these patients will have very soft spleen. And therefore, they're very prone to get injured. And if there is an injury, they will rupture the spleen very rapidly. There are many other complications which also occur. EBV virus can also cause meningitis, transverse myelitis, even Guillain-Barré syndrome, and ataxia. So it is not a very simple infection to have. So, sir, would you like to add anything on this?
Fine. I think you have already told that the splenic rupture is mainly because of the subcapsular splenic hemorrhages, and this normally occurs in the second week of the disease. And strangely, the trauma is the underlying cause, but trauma are usually very mild and it is really fatal. So even if there is a splenic rupture, probably most of the children would survive. And even with the mild trauma also, they can have a rupture. As you said, that spleen is very soft and there are hemorrhages. And I think dengue fever, we all know that it has got a different type of fever, rashes, and along with that, the PCV hemoglobin is all increased. So this is a different sort sort of a ball game for as fever is concerned compared to the EBV. And we do have splenomegaly in dengue and other infections, but then we don't have the splenic ruptures being seen in things like dengue fever. Thank you. Thank you.
So let us look at how many people have got it correct. 80% have replied for all of the above, which is not true. So I think, what was happening, sir, was that the questions with all of the above were very easy because they all knew that they had to put all of the above. But I think this was, googly. So they got bowled out. So let's see anyway in the 15% who has got it correct. Fastest, Jivansha Dua. Very good. I think Jivansha, congratulations. You got a correct answer and in good time, 8 seconds. So this I think they should remember, these people should remember that this is EBV and the others do not cause splenic rupture. So can we go to the next question, please? So the following are used in the treatment of FAPA syndrome. So FAPA's syndrome, except low-dose steroids, Montelukast, tonsillectomy, and adenodectomy. Your time starts now. So let us look at what is the correct answer. So here the answer has been given as Montelukast. So this was a question that all others can be used. That means we can use low-dose steroids, we can do tonsillectomy and adenodectomy. Now, FAFA, the full form is periodic fever, aphthous stomatitis, pharyngitis, and adenitis. And this is an inflammatory disorder, an autoinflammatory disorder caused by an inflammasome, which can be of oligenic or polygenic background. And there are some diagnostic criteria. Usually it occurs from 2 to 5 years of age. So the children have to be less than 5 years. They should have recurrent fever with the absence of URI, and at least, they could have aphthous stomatitis, cervical lymphadenopathy, or pharyngitis. And what is interesting is in between, these children are absolutely normal. And nothing works excepting for steroids, tonsillectomy, and adenodectomy. So you want to add anything else?
Right. I think you have said most of the things. Just wanted to tell that this is the most common recurrent periodic fever syndrome in the childhood. And steroid doses we normally give is 1 to 2 milligrams per kilogram as a single oral dose, which suffices. But strange thing here, Dr. Rachna, is that this does not prevent recurrences of the episodes. And in fact, rather, they say that it may shorten the interval between the flares. So if the child is having every 4 to 6 weekly fever, and we give a dose of steroids, so the fever will come down now, but maybe the second episode may occur more frequently. So sometimes it may be working for today, but it may not work for the next time. And another drug, cimetidine, has also been tried in decreasing the recurrences, and almost 1/3 of the it causes recurrences in 1/3 of the patients, not in all of them. So cimetidine again is another drug which can sometimes, and tonsillectomy, adenectomy, as you said, that sometimes doing these procedures brings down the episodes of fever again and again. And PFAPA, when we were students, we were not knowing about this condition earlier. And trust me that we had children who would have fever every 4 to 6 weeks. We didn't figure out the cause, and they would have enlarged tonsils and sometimes lymphadenopathy. And our ENT friends would say, get their tonsillectomy done. And we would say, why remove the tonsils? They are protective in nature. But they would insist, and I can tell you, I have personal experience where I had to get 2-3 children getting tonsillectomy done, and after that their fevers just disappeared. So maybe they were having PFAPA type of condition where we were not knowing the name of the condition, but we knew the treatment tonsillectomy helped these children, and recurrences did not occur. Thank you. Thank you, Dr. Rachna.
So I think we will look at the answers. How many people got it right? Okay, 42% have got the correct answer, which is not bad, considering that it's a recent, addition to autoinflammatory disorders. And maybe know who's the fastest in this? Kunal Kashi again.
Oh, great.
Great, Kunal.
Yeah, Kunal is doing well. 7
Tough
seconds.
competition. We have 2-3 people who have given fastest answers in the last 12 questions. So let us go to question number 13. So look at the picture carefully and I will give you the history. A 2-year-old child is presented with high fever, poor feeding, sore throat, drooling, and on examination, there are very small vesicles and ulcers, as you can see on both the tonsils and palate. So what is your diagnosis? Herpingina, measles, herpes gingivostomatitis, or acute streptococcal tonsillitis. Your time starts now. So can you just show us the right answer, please? You see, if you look at this, I think most of us will think about tonsillitis, enlarged tonsils. But the catch here is, I think, the high-grade fever with the poor feeding because of these small vesicles which are there in the palate. They're extremely painful. And we are seeing a lot of them these days, usually caused by Coxsackie viruses. And the close differential would be the other forms of vesicular lesions, that is hand, foot, mouth disease. Would you like to add anything, sir, in this?
Right. And in measles, we have rash, but they are Koplik spots and the site is not like tonsils. And again, herpes gingivostomatitis, as the name suggests, this is caused by the herpes virus, simplex virus, and there are mucosal hemorrhages, and the vesicles are present in the mouth. Small vesicles are present all over in the mouth, not only in the tonsillar pillars, as seen in herpingina. And again, there may be perioral skin and lips may be involved in gingivostomatitis. So that is how we differentiate between them. And of course, we know about the streptococcal tonsillitis already informed. So we have to see the lesions, where they are occurring, how they are, whether they are in clusters at site, and whether they are like vesicles. So we can differentiate between these conditions.
So can we have a look at the answers? Okay, 40% of the people thought it is streptococcal tonsillitis. But I think you should look carefully at the lesions. In streptococcal tonsillitis, you will not get these dots of red dots surrounded by erythema. They would be more of exudates on the tonsils. And usually streptococcal tonsillitis occurs at 5 to 15 years of age. So in a 2-year-old, the most common would be either hand, foot, mouth disease or herpingina. So Dr. Prabhjot has got the fastest. So congratulations, Dr. Prabhjot. And he took only 5 seconds to answer it. So I think very good. Can we go to the next?
One thing was very clear, that everybody knew that it is not measles. So there was a zero.
Yes.
There was a 0 voting for measles. So they're all very clear about measles. Though they may not have seen Koplik spots, because we hardly see measles these days.
Yes. So let us go to the next question. Question number 14. So 5-month-old female child born of consanguineous marriage presented with cough and breathlessness for 8 days. The first child of the family had succumbed to death at the age of 4.5 months. The present child was admitted and treated for sepsis. The patient had oral candidiasis and bilateral purulent eye discharge. Clinical investigations revealed a total lymphocyte count of less than 3,000. And the X-ray picture is shown below, shown there. You can see the X-ray, look at it carefully. So what is your diagnosis? What condition does this child have? A, leukocyte region defect. B, CGD or chronic granulomatous disease. C, DiGeorge syndrome. And D, Wiskott-Aldrich syndrome. Your time starts now. So let us look at what is the correct answer. So DiGeorge syndrome is the correct answer. The answer was there actually in the X-ray. And if you can see the X-ray, there is no thymus. The thymic shadow is not there. And this is a small child, a 4.5 to 5-month-old child with a positive family history. So these are the conditions which is congenital and occurs because of microdeletion in chromosome 22. And there is a defect in formation of the organs involved in the pharyngeal pouch. So there'll be ear defects, there'll be defects of the maxilla, of the tonsils, thyroid, the parathyroid, the aortic arch, and the heart. So most of them would have recurrent infections, early recurrent infections, because of absence of the thymus. The thymus is the one which will give you the T cells. So if the T cells are not there, then you will become prone to early bacterial infections. And not only bacterial, but also fungal. So as you see in the history, there is a pneumonia, there is also oral candidiasis and some eye discharge. And because of the problems with the parathyroid, these patients could also have hypocalcemia. And the treatment of choice is prophylaxis with antibiotics and IVIG recurrent, and of course, completing the normal vaccination process. So would you like to describe anything of the other conditions? So you're on mute.
Okay. So you've already told us about the DiGeorge syndrome. So I would just like to tell a line about the leukocyte adhesion defect, that in this defect, again, there are multiple infections and there is leukocytosis, but no leukocytes are seen in the cells to fight the infection. So though there are a lot of leukocytes present and there's leukocytosis, but at the site of infection, the leukocytes are not present and they do not enter the cell, leading to recurrent infections. Again, we have already talked about the chronic granulomatous disease in detail earlier. There are again non-responding infections, recurrent infections, and leukocytosis, thrombocytosis. And about the Wiskott-Aldrich syndrome, again, we see thrombocytopenia is one of the characteristic finding. Here, the platelet number is not less. There's a low mean platelet volume and decreased platelet size. So what we need to look at in this syndrome is not the platelet number, but the platelet size and the platelet volume, which will give us the idea about the Wiskott-Aldrich syndrome. Right, I think you've already talked about DiGeorge in detail.
Yeah.
That's
in Wiskott-Aldrich, the classical finding is that of eczema. So they have immunodeficiencies, so recurrent infections, they'll have thrombocytopenia, as I said, and there will be an eczema. So let us look at the answers. So 37% A, 37% C. Okay. So who has got it correct? Jivansha Dua. Very good. So Jivansha Dua has got the correct answer. We are having very tough competition, sir. Many of these people have got fastest finger 2-3 times. So which is very good. The competition is extreme. Let us go to the next question. Question number 15. So a 5-month-old presented with high-grade fever for 3 days, coryza, mild cough, congested eyes, and maculopapular rash, starting from the nape, which subsequently progressed all over the body. So the choices are there in front of you. Please give the answer. Your time starts now. So the correct answer is measles. So would you like to say something about measles? Because at your time, I think you saw lots and lots of cases of measles.
Yeah, we
What
did
do you see
see,
now?
we used to see a lot of cases of measles, and I think it was quite a dreaded disease earlier because it would have a lot of complications, especially ear infections, pneumonias, and we used to lose many of these children because of the subsequent complications of the measles rather than the measles per se. And again, after the vaccination and the vaccination programs, the disease has starkly come down, and we hardly now see measles. And if you have to teach about the measles, we have to show the picture to the students rather than the cases per se, which is again a good thing. I think not having a disease is better than showing the disease to the students. And again, about the other conditions, we have already talked about the dengue. Again, the rashes in the dengue are classically little different. And we have low platelet counts, which is very classical. And in dengue, we see sometimes islands of white in Red Sea. And these are when the child is recovering, we see these classical islands of white in Red Sea. And if you see that, you can assure the parents that now it's probably going to end. The fever has settled and disease is going, and itching also starts along with it. And again, I think nothing much to say about the measles more.
So here, I think the students still need to learn about measles. Keep this particular, the rash is very classical. It starts from the nape or the forehead, and then it progresses. With every fever, there will be a fresh crop of rash which occurs. And coryza and congested eyes, which are sticky, are very important. Don't go away with the fact that you don't need to know about measles because the vaccination is doing quite well. There are many examples of recent times from Western countries where there has been a measles resurgence because they have stopped using the vaccine. So let us look at how many of, I'm sure 100% have got it correct. So let us look at the results.
D.
59.
Oh. No, not. It's disappointing. Only 60%. It's a classic, I think, in our days, classic example that the rash is starting from the behind. We would look at behind the ears immediately. The child has fever and some congested eyes. We would look behind the ears, and if the rash is present, probably we would say that next 5 days the rash will go down. And we used to tell them day 1 on the face, day 2 on the chest, day 3 on the lower abdomen, and day 4 on the legs, and by 5th day it would disappear. And that is how we used to convince them that this is measles and it will take time. Otherwise, these patients were going on to the homeopathy or other alternative medications and local treatments of all types, that this is something bad. But I think 60% we needed 100%.
The final message from this question and the pattern of answer is that all of you need to go and read about measles and remember it, because don't go home with the idea that you don't see them. Once in a while you do see cases. So let us look at who was the fastest and the correct answer. Kunal Kashi. I'm telling you, sir, these boys are very good.
Yes.
Multiple times I've seen.
Very nice.
So very nice. Let us go to the next question. So question number 16. 9-year-old girl had fever, sore throat and rash for 3 days. The characteristic presentation include acute febrile illness, sore throat, goose flesh, or coarse sandpaper rash within 12 to 48 hours. Most intense at pressure areas such as axilla and groin. Bastiers line, strawberry tongue and pustule. Desquamation begins towards the end of the first week. What could be your diagnosis? Your choices are classic Koplik spot measles, hand, foot, mouth disease, roseola infantum, or scarlet fever. Your time starts now. So let us look at the correct answer. The correct answer, please. So, sir, I think this, when they have listened carefully to the previous question, they should have been able to give 100%, should have been able to tell that this is scarlet fever, isn't it?
Absolutely, absolutely. I think we have already talked about it in detail when we talked about the sandpaper rash earlier. And right, and I think I would just like to, measles we have already talked about. Hand, foot and mouth disease is something which is, at least in our northern part of the country, we are seeing it so rampant now that some of the schools, junior schools had closed down of late because the disease was spreading like a wildfire. And again, it's important that the students should know about the hand, foot and mouth disease caused by group A Coxsackie virus. And it normally takes 2 to 7 days. And the rashes are classically on, as mentioned, on hands, feet, and the mouth. But these days we are also finding rashes on the elbow, sometimes on the buttocks, and even on the groin. So it is not restricting, the rashes are not restricted to these three areas which are mentioned as in the disease itself, but other areas can also be affected. So what's your experience about this disease in eastern part of the
epidemic of hand, foot, mouth disease, sir? And every day I'm only seeing 3-4 patients. So the experience is the same with our other colleagues. Some of them have, schools have given, like sort of warned the parents. So most of the parents are not sending. But I think it's what one should remember, it's a very highly infectious disease. And I have been seeing hand, foot, mouth disease for the last 12 years. But this time it has been like too much. It is too much outbreak. Probably because children were at home in the last 2 years and there was some immune deficiency, like, you know, immune, what do you call it? They were not exposed so much. So I think now when they have come out and gone to schools, the exposure is there and the effect of the infection is quite severe. Some of them have stopped drinking, or we had to admit a few patients also.
Oh, really?
Yeah, because of excessive pain in the throat and not able to eat or drink.
So exposure to subclinical infections probably helps these children in building up the immunity, and being at home for last 2-3 years during the COVID times has in fact brought down their immunity. Yeah. So
let us look at how many of them have got it correct. 76.4%, not bad, not bad. So let's see who has got the Kunal Kashi again.
Wow. Oh, great.
Great, great. So let us go to the next question, please. Question number 17. So again, a long question. Listen to it carefully. A 10-year-old child presented with icterus and altered sensorium. He had taken some herbal medication earlier as a treatment for fever. Investigation showed anemia, thrombocytopenia, a serum bilirubin of 6.2 milligram per deciliter, SGPT of 98. Child had continuous hematemesis and purpuric rashes, and the provisional diagnosis considered were sepsis with multi-organ dysfunction, meningococcal septicemia, and rickettsial encephalitis. Since the child's condition was deteriorating, peripheral smear was carried out and the result shows the presence of Burr cells. So what is the most likely diagnosis? A, purpura fulminans, B, thrombotic thrombocytopenic purpura, C, rickettsial fever, D, dermatomyositis. Your time starts now. let us look at what is the correct response in this. Correct answer is thrombotic thrombocytopenic purpura. I think in children it is not very common. It is more of a disease in adults. But there is a congenital variation which can be seen, variant of TTP which can be seen, and this mostly occurs in females. And this is because of a congenital absence or deficiency of the von Willebrand factor clearing protease. And therefore, what happens is that the blood vessels get clogged because of thrombus, and therefore there is a multi-system involvement with bleeding, CNS involvement, hematemesis and all. And most of them would respond very well to steroids. So you want to add anything in this?
Yeah, I think one of the treatments which sometimes we require to give to these patients is plasmapheresis. And occasionally we get very sick patients who need this sort of a therapy. And about the other conditions, I think equally important that purpura fulminans, which is again not uncommon to see. It's a very bad disease with necrotic patches, and these children come with gangrene on the ear, gangrene on fingers and toes, and sometimes there's autoamputation. And I think rickettsial fever, we have already talked about it quite a bit. About dermatomyositis, again, these children have recurrent fevers or high-grade fevers, again inflammatory fever with a lot of weakness, and there may be classical heliotrope rash on the eyelids. These are eyelids, the rash appears as purple color. They may be on the eyelid or they may be around the eyelid. And sometimes there is calcinosis cutis also being present. So these are little uncommon conditions, but again, we need to keep them in mind. Once we have these difficult conditions which are mimicking, we should be able to differentiate them. Thank you, Dr. Rachna.
Yeah. So purpura fulminans is Neisseria meningitis, extremely fatal disease if you can't do the diagnosis at the correct time. You may get multisystem involvement and have some icterus in it. But in rickettsial fever, usually there will be transaminitis but no jaundice and no bleeding as such. And in dermatomyositis, as Sir has nicely described, this is an inflammatory disorder, immune related. So here the rash is very classical and there is proximal muscle weakness. So can we see how many people have got it correct?
Oh, great.
Wow, nice. 65%.
Yes.
Let's see who's got the fastest finger. Mehak Bhatt. So very good. Congratulations, Mehak. So can we go to the next question, please? So a 7-month-old breastfed girl child presented with a history of ear discharge at 4 months of age, severe pneumonia and oral thrush. HIV was negative. Chest X-ray revealed the absence of thymic shadow and the absolute lymphocyte count was only 1200. Based on the findings, what is your diagnosis? Is this a case of chronic granulomatous disease, Wiskott-Aldrich, leukocyte adhesion deficiency, or severe combined immunodeficiency? Your time starts now. So let us look at what is the correct answer. So the correct answer is severe combined immunodeficiency or SCID. And if you know about SCID, you will say that this is an X-linked disorder. How come the girl child is affected? Because if it's X-linked, usually it's the males who will get the disease. But here our question says female. So this is also known, it is nowadays known that there are various kinds of SCID. The most common one is X-linked, and the others are because of adenosine deaminase deficiency. So in those ADA deficiencies, you can even have females being affected. Here, it is profoundly deficient in T cells and B cells, and that's why these children at very young age they will get very serious, small infection can become very serious and they succumb very fast. The only modality of therapy is hematopoietic stem cell transplant, which is curative. And nowadays there is a recommendation in some of the countries that how do you diagnose them at birth or immediately after birth. So what they say is that you can look at the blood picture and look for T cell receptor excision circles, which are actually some things, these T cells, they during the process of development, the receptors, they will undergo some breakage and they form circles. So they're byproduct of T cell development. So if you can count these number of cells, if they're there, then means the T cell is functioning well. If they're absent, it is an indirect indicator of that your patient or your baby may have a severe combined immunodeficiency. So would you like to add anything if you've seen any such?
Yeah, I think all these conditions we have described earlier, CGD, Wiskott-Aldrich syndrome and LAD. I think we have already talked about these conditions and you have quite in detail told us about the SCID also. And I think we can look into the answers.
Yeah. So let us look at how many people have got it correct.
Answer D, very nice, almost
Nice.
55%.
Yeah. 55% have got it correct.
Yeah.
So let us see who got it the fastest. Jivanshu Dua. Oh, great. Let us go to the next question. Effectiveness of timely hepatitis B immunoglobulin and vaccination in preventing mother to neonate transmission of hepatitis B is more than 70%, more than 90%, more than 95%, more than 80%. Your time starts now. So let us look at what is the correct answer. I'm sure many of them will get it correct. So the correct answer is more than 90%. So it is said that if you have a mother who is hepatitis B positive, then it is immediately we should give an immunoglobulin and also the first or the 0 dose of hepatitis B vaccine to the neonate. And if you can do this, then you are preventing transmission by more than 90% of the cases. So, sir, anything you want to add about
Right.
this? This is a very important clinical question, actually.
Yeah. And I think with the advent of hepatitis B vaccine and then vaccine being used as a 0 dose right from the birth in just after the delivery and being availability of the vaccine throughout the country, definitely the incidence has gone down and the efficacy again is more than 90%. So I think it's a very important modality and the question, and I think we all must be aware about it. Right. Thank you.
So I hope everybody has got it correct. Let's look at the answers, please. Nowadays, we rarely get patients who are mothers who are hepatitis B positive. Very rare.
The vaccination has improved the status quite a bit, and the availability is acceptability is also good.
Yes. And I think hepatitis B vaccination universally started very early in our country. I remember in 1994, we were given the first dose as students. So I think most of the mothers now are all vaccinated against hepatitis B. So can we have the answers, please? There was a confusion between 90 and 95%.
I think not to blame because there's a small gap. So
Yeah.
90 and 95, all those who have answered both, I think they are nearly correct, but we have to give it to the correct answer, 90%.
Let us see who got it fast. Sahil Chauhan. Okay, Sahil, very nice. Congratulations. Let us go fast, quickly to the next question, please. A newborn with HIV infection diagnosed with RNA polymerase chain reaction. What is the drug of choice for pneumocystis 0HE? Is it cotrimoxazole, it is trimethoprim, rifampicin, or clotrimazole? Your time starts now. Okay, let us look at the correct answer here. So the answer which has been given is cotrimoxazole. If you can see that in B, we also have trimethoprim, but that alone will not work. It is always trimethoprim with sulfamethoxazole. That's why the correct answer is A. Sir, have you in your clinical practice been seeing patients, newborns with HIV or children with HIV?
No, I think HIV is being seen by a different branch altogether. And in private sector, we don't see much, but in government sector, they are seeing, and they have separate sections who are looking at HIV infection. And I think cotrimoxazole and clotrimazole both were kept here just to confuse the but clotrimazole is an antifungal and entirely a different thing, but I think similar names. And again, about this pneumocystis 0HE, I think this is an organism which in all the immunodeficiency syndromes, this is the one and fairly troublesome. And the only drug of choice is clotrimazole. So any of these conditions where there is immunodeficiency and this organism is there, I think we have to be a little careful that not very many choices for its treatment.
Yeah. So even we don't manage HIV patients because we have the NACO which manages so well. So we send the patients to them and they also get the medicines free. And I think for managing patients with HIV infection and disease per se is you have to be totally, into it. You can't do any other thing. It's because of the drugs, the doses. They're so much different from what we normally prescribe. But it is important to know that there is a unit which manages this separately in the government sector, like for TB patients. And what is important is also that for all TB patients, you have to do HIV testing, and for all HIV patients, you have to also look for tuberculosis. So let us look at
because the HIV disease treatment is a prolonged treatment,
yes.
And that's why a dedicated team, as you said, Dr. Rachna, that we need, because the child keeps growing and then the weight keeps increasing and the dosage has to be changed very often. And if these children are seen on OPD basis only, they come once and then they disappear for 6 months. They may be underdosed. So they have to be followed up by a dedicated team who keep a track of them, and then they keep changing the dosage as per their age and weight also.
Yeah. And I think the monitoring is not done with a routine, the routine way we do CBC and all that. It is done by CD4 counts. So that is also available in the government sector. And that's the reason I would not manage any HIV on my own. So can we have the next, the answers? How many people have got it correct?
Oh, great.
Wow, good. They did not get fooled, sir. So let us see who got it the fastest. Mehak Bhatt. So we have come to the end. I think this was question number 20. And congratulations to all of you who have participated so enthusiastically. And I know who are the two ones who have got the fastest, because I kept a track, but we will allow our IT team. And I am sure we are not going to have any other questions anymore. No time.
Immediately you start at least 2025 pilot study and result is required.
Mr. Jairaj, please, sir, kindly mute, sir. Mr. Jairaj, sir. Yeah.
So
Right.
I think they have done extremely well today. Questions were tricky. Sir, what do you say?
Yeah, there were some of these were little difficult with so many of these immune deficiencies and uncommon fevers and uncommon symptoms. But I think many of them have answered well. And some questions, of course, were a little tricky. But overall, it was a good performance. So let's see that who have been the fastest amongst the winners also, amongst the correct answers also.
Yeah. So, ma'am, we can tell them we just wait for a few more seconds. We will be announcing. Meanwhile, I would also want to make one more announcement on another PG activity which we are going to be starting like last year. This year also we are going to have the postgraduate poster competition for all the postgraduates in pediatrics. Can Abhira or Dr. Krishna share the slide, please? This will be electronic form. You need to submit your poster in e-form only. No hard copy or photocopy of the hard copy is also not allowed. So we are going to share a template, one PPT slide. So you need to submit that PPT slide in that format for all your posters. So can you make it full screen? Yeah. And see, this poster is in preparation to our 5th annual conference of Fever Foundation, FEFCON 2022, which is going to be held on 5th and 6th of November. And our scientific committee will examine the posters, and they're going to call for top 10 poster submitters for making a presentation. And they will evaluate the posters online. And the link will be shared to you where you can download the template which is shown here. Your poster can be composed of either research template, research based, or it can be case based. And the ratio of the PPT slide you need to use 16:9 ratio. That means the wider screen one. And it should be done in the same format as shown here. And you can download the format as I mentioned. Next slide, please. And some of the guidelines for submitting your virtual poster presentation, as I've clearly mentioned, we only accept electronic posters, e-posters in PowerPoint format only. Printed posters or photograph of the printed posters will not be accepted. And the topic should be related to fever. Please note, it has to be related to fever. It can be research-based or it can be case-based. And category of participation, you can use when you register a drop down button to select whether it is case study or whether it's original research paper. And when your poster is selected for presentation, only the first author will be allowed to make the presentation to our esteemed scientific committee. And poster to be submitted as per the template, otherwise it gets disqualified. And your title of your poster, the word should be less than 15. And along with the one single side PPT format, you need to also submit an article related to this case or research. And this minimum number of words in this article should be 500. And the format in which you will send the word file is Indian Pediatrics, the official journal of IAP, in the format you will be sending. The acceptance of the poster presentation is entirely on the discretion of our scientific committee, and their decision is final and binding. So for any query on the poster related things, please mail to us at feverfoundation@gmail.com. And all participants will get participation certificate, and the winner is going to get attractive prizes. So all posters which have been submitted and selected will be available in FEFCON conference. If FEFCON going to be hybrid conference, so it will be virtual platform. There will be a dedicated poster hall. It will be available on the virtual platform. So more on this, you will be getting these links, and we will be sending it to your colleges to be displayed on your notice boards. And also those who have registered for quiz, we will be sending you all by email also all this information. Okay, so please looking for the case, or if you are already having interesting case, kindly present this. And so I think I will just check whether our IT team is ready for announcing the winners. You can tell us. Yeah. Please, madam and sir, please announce.
Visible, yeah. Yes.
Yes, sure.
So, with Praveen and Yash, actually, we are a 2.5-year-old organization. When
Yes.
we're actually
So this was what was my result also, because I was keeping a track. Kunal Kashi from PGI Chandigarh and Jivanshu Dua from UCMS Delhi. In fact, Kunal got, fastest finger first, 5 questions. And Jivanshu, she got 3. So congratulations to the winners. I think they've done an excellent job. I'm so proud of Kunal because he's from my alumni. And also equally proud of Jivanshu because I think she's from Delhi and from Dr. Anand's.
Yeah,
City.
city. Yeah, but they're all students and they're all dear to us. And I think all those who have participated, it's more important that the participation is more important than winning alone. But our congratulations to both the winners, Kunal as well as Jivansha. And we will see them later in our final quiz after all the zones have had. And keep it up. And I think the questions which were given today were little easy. Some of them were easy, some little tough. But in the final rounds, you will get little more tougher questions. So get going and get prepared for the final rounds also. And all the best to both of you.
So just to add to that, Dr. Kunal, once again, and Dr. Jivansha, congratulations to you. But I would like to inform you that both of you will be playing as North Zone team. You will not be playing individually for the finals. So you will be representing entire North Zone and you will be playing as the North Zone team. Our team will exchange each other's contact details so you can be working together. And then, so wish you all back. And you will be coming down to Bangalore. So our team will get in touch with your travel and other things. So you will come to Bangalore on November 5th. Is the quiz. So 5th and 6th you will be in Bangalore. So our team, Mr. Praveen and Ms. Abhira will get in touch with you for more details. So congratulations to the winner once again. Winner, yeah. So if there are no anything else, with the permission of the judges and all our colleagues, can we close this meeting?
Yes, excellent meeting. Pleasure. And it was so refreshing to have gone through all these questions along with the youngsters.
All the participants, sir, will get a participation certificate. So our team will send you this certificate.
And also the quiz masters. We'll also get the participation.
Because you have put in more effort, actually. Lots of work has gone.
So send the certificate along with a gift then.
So only certificates, sir. No gifts.
You can stop recording.
No. Yeah.
Because of UCPMP.
Yes. I get your point. Just as in the lighter vein.
Yeah. So thank you all for a wonderful participation. Thank you. Can we stop recording now?
Thank you.
Once again, thank you, Dr. Anand Vasudevan sir and Rashma madam. Thank you.
Recording
Very much.
Thank you, Dr.
Sir.
Jayaraj Krishna.
Morning, everyone. So it gives me very immense pleasure to welcome you all to this edition of Fever Foundation first ever quiz on fever related information and subject. And thank you all for registering and participating in the quiz. And now I will be just quickly running through the rules of the game, although all of you have been sent through a mail and then through your registered numbers. We have sent you all the details. But quickly, I'll be running through the what are the rules of playing this quiz, and then I'll be handing you and I'll be introducing our quiz masters for and the judges for today, and then we will be starting the quiz. So can we have the slides, please? Yeah. So this is a scientific initiative from Fever Foundation. So you will be playing for the North Zone today. Yeah. Next slide. So the rules are the quiz is for only for the postgraduate students only. The quiz consists of multiple choice questions. There will be 20 such questions in the quiz, and you will have 20 seconds to answer each of them. Now, the option to be selected by clicking on the text panel on the right hand side. So there will be a video displaying the option, but it is only for representation. You cannot click the button on the video. On the right hand side, you have a text panel where you need to click the button and select your option. And the participants are advised not to leave this platform and go to the YouTube. You cannot play the quiz on the YouTube. YouTube is only for viewing purpose. So you please stay on this platform for the entire quiz. So you will be able to only answer through this platform only. So therefore, please do not leave this platform until we complete the quiz for today. Once submitted, you will not be, it is not possible to revert it. There is no negative marking in the quiz. The winner will be selected on the maximum far right answer. Fastest finger, fast answer will be the winner. And in the event of tie, we will have a tiebreaker round, which will have 3 questions and to decide the winner. So it is advisable to use the laptop or desktop for a better experience of this quiz. Next, please. And it is also advisable to have in a place where there is good internet connectivity because it's an online quiz. And if our team finds any type of foul play, you will be automatically disqualified. And you should not use mobile phone for getting the answers from any of your colleagues sitting nearby. And Fever Foundation is not responsible for any form of technical error, such as poor internet connectivity, etc. Participation in the quiz implies that participants accept the integrity of these rules. The participants who have given incomplete or inaccurate personal or contact details will be disqualified. Non-compliance with the rules results in the automatic cancellation of the participation in the quiz and the candidacy for the prize. And please note that first and second winners will be selected today. And the first and second winner of this North Zone quiz will play as a team. You will be representing the North Zone and you will enter into national level quiz competition, which is FEFCON, which will be on November 5th and 6th at Bangalore. So you will be coming to Bangalore as a team to participate or to compete at the national level quiz. And the last and very important, our quiz master and judges decision will be final. All of us are binding by their decisions. So these are the rules, and I wish you all good luck for playing the this quiz, and may the best student win the quiz. And I would like to introduce our esteemed quiz master and judges for today. Next slide, please. Professor Dr. M.K. Sudarshan sir, MD, FAMS, Honorary FFPH from UK. Sir is the chairperson of Karnataka State COVID-19 Technical Advisory Committee of Government of Karnataka. He's a member of our advisory board of Fever Foundation. He's ex-director and currently holding a special post at above director's position at and also he was retired dean and principal and professor of HOD of community medicine in a reputed medical college, Keppegoda Institute of Medical Sciences, Bangalore. He's a member of WHO Expert Consultation on Rabies, Geneva. He's a chairman of Ethics Committee of Bangalore Medical College, Fortis Hospital, Bangalore, NABH assessor in clinical trials and ethics committee, New Delhi from 2015 till date. He has more than 100 publications in international and national index journals. He has authored several books on rabies in English, as well as he's written a lot of books for patient education in Kannada. Best Teacher Award from Indian Medical Association for Karnataka State in 2003. Government of Karnataka and Dr. B.C. Rai Awardee for Award for Achievement of Excellence in Medical Education. His government of Karnataka recently bestowed him with the Rajyotsava Award, which is a prestigious award for the Karnataka government for his exemplary work in COVID in 2021. And he was also recognized for his commitment and the work in the COVID-19. So government of Karnataka bestowed him Dr. Day Award in recognition of COVID-19 work in 2022. And Rajiv Gandhi University Health Sciences, he got the Eminent Teachers Award in 2022. Dr. Sudarshan sir, it's pleasure and privilege to have you with us as the judge sir today.
Thank you, madam. Thank you. Thank you.
Our another judge is another and the quiz masters. I'm going to run through it. Dr. Professor Anupam Prakash sir. He is MBBS MD, PGCC Hospital Medicine, General Medicine MD, and PGCC in the Hospital Management, PDCDM, FICP, MNAMS, FACP, and FIACM. He is currently the Director and Professor of Medicine and Head of Department of Accident Emergencies at Lady Hardinge Medical College and Associated Hospitals, New Delhi. He is Editor-in-Chief of Indian Journal of Medical Specialties, Associate Editor of API Textbook of Medicine, and member of governing body of API, President, Board of Management, Delhi Diabetic Forum, President of Indian Society of Atherosclerosis Research, and Vice Chairman of API Delhi State Chapter. He is member of several professional advisory boards, to name a few: Advisory Board of JAPI, JIACM, and Journal of Case Report. He is also advisory board of member of our Fever Foundation. Welcome, Dr. Anupam sir. It's a privilege to have you.
Thank you for a cordial welcome. Thank you so much.
And Dr. Jayant Pada is our another judge over here. Sir is a professor and head of the Department of Medicine at SCB Medical College, Cuttack, Odisha. He's a consultant in diabetes, metabolic, and critical care. He's a national president of CCDSI, chairman of API Odisha State Branch, governing body member of National API. He's organizing secretary of RSSDI 2017. He is also in the advisory council of governor of ACP of India and member of CWC IMA. He has several publications, more than 17 publications in national, international, peer-reviewed medical journals. He's been the principal investigator of many national and the global clinical trials. Sir, Dr. Panda, sir, it's a pleasure and privilege to have you as a judge here, sir. Welcome to you, sir.
Thank you. Thank you.
And we have Dr. Ghanshyam Pangte, sir, Professor of Medicine, Lady Hardinge Medical College, New Delhi, Rheumatology and Medical ICU in charge at LHMC, New Delhi. He's the Joint Secretary of Indian College of Physicians and API Delhi Chapter, Executive Member of Delhi Rheumatology Association and ISER. He's Associate Editor, API Textbook of Medicine, 9, 10, 11th edition. He has published more than 100 publications in index and non-index articles in reputed journals. He's a co-edited more than several books, to name a few: Pearls for Scientific Paper Writing, Research Methodology and Ethics in Clinical Research, and PRF. And he is also a very well-known teacher, medicine MD and NBE postgraduate teacher and examiner of Delhi AIIMS, Rajasthan. So, Professor Dr. Ghanshyam sir, it's pleasure and privilege to have you with us, sir, today. Next. And Madam Dr. Subbalakshmi Margekar, she is the Professor, Department of Medicine at Lady Hardinge Medical College, New Delhi. She's a Fellow of Indian College of Physicians and Fellow of Association of Clinical Medicine, Coordinator in Chief Thalassemia Adult Daycare Center and Thalassemia Transition Care Center at Lady Hardinge Medical College, recipient of Dr. J.C. Patil and J.C. B.C. Mehta Award in Epicon 2014. She's been the faculty in Epicon from 15, 18, 19, and 20. Faculty and organizing team member of API, DSC CME in 2019. She's been in the organizing committee and faculty in the team member of Diabicon 15, 16, 17, 18, 19, 20 as well, and delivered lectures, several lectures to name a few, Epicon, Diabicon, various other CME. She's been most sought after teachers and lectured across several professional conferences, participated in several multicentric international clinical and the national clinical trial, and he has guided 12 postgraduate students in their theses, and has several publications to her credit in peer-reviewed medical journals and books, and she's been part of the API textbook of medicine and medicine update. Dr. Subbalakshmi Madam, again, it's a privilege and pleasure to have you with us as the quiz master, ma'am. And we have Professor Dr. Ramesh Agarwal, sir. He is MD Medicine, FRCP UK, FICP, MNAMS. Presently, sir is working as Professor of Medicine at Lady Hardinge Medical College and Associated Hospital, New Delhi. He is a recipient of prestigious Srimati Pawan Kumari Jain Oration Award for outstanding work in the field of internal medicine. Chaired session and delivered lectures in various national and international conferences, to name a few, Diabicon, API, DSC, Epicon, annual conferences, etc. And he has also served on the board of management of Delhi Diabetic Forum. He has more than 70 publications in the national and the international journals. He has presented his paper in several national and international conferences. Dr. Professor Ramesh Agarwal, sir, again, I welcome you to this session, and I request you to be the
Thank
quiz
you, madam.
master.
Thank you for your kind words,
Pleasure,
madam.
sir.
Thank you, madam.
So, and now, may I now request and hand over to our quiz master, so Dr. Anupam Prakash, to take over first, and then others to conduct the proceed. Over to you, sir.
Thank you. A very good evening to everybody. Thank you, Fever Foundation, Dr. Manjula, Mr. Jayaraj, and thank you, judges, Dr. Sudarshan, Dr. Panda, and Dr. Ghanshyam is also there. Well, thank you so much. And the responsibility today that has been given or entrusted to us is to conduct the quiz for the North Zone. And incidentally, we happen to be sitting in the North Zone right now. But it is going to be an interesting quiz. We are already halfway through. We had 2 zones yesterday and day before. And after today, we will have another 1 quiz to be conducted. So 2 candidates, as Dr. Manjula has said, 2 of you will be participating and getting the first and second rank, and you will participate as a team together. And I think we will start the quiz without any other delay. Dr. Subbalakshmi and Dr. Ramesh and Dr. Ghanshyam are all there to take us through today's quiz session. And I will request Dr. Sudarshan and Dr. Panda to give their inputs. So can we start the quiz? So we have Computer G there. Yes, I can see Computer G is there. And the scorer is also there. So everybody has to be on now. We will have a couple of dummy questions. I think we have some dummy questions for candidates.
Yes, three dummy questions will
So
be
we
there.
have 3 dummy questions. Also, although it is teen tigada kaam bigada, but still, I hope it is 1-1-1 triple Nelson. So we will have 1-1-1. And Nelson was a great person. 1-eyed, 1 hand, and 1 foot. And still he won a long battle. He defeated Napoleon Bonaparte, who was the ruler emperor of UK. Unfortunately, we had the Queen Elizabeth, who has left for her heavenly abode. But anyhow, Computer Ji, I am just waiting for the first dummy question, talking to the participants. So best of luck to all the participants. We are here today. Yes. Great. So I am very poor at films, and the dummy question has something to do about films. But yes, postgraduates would be definitely very active about it. So the question is, which film is India's official entry for the 95th Oscars? Kashmir Files, Chalo Divas, Chalo Show, and RRR. So if answer, please, all of you should attempt it. A, B, C, or D. The timer has begun. Yes, 20 seconds you get for each question. For me, RRR is relative risk ratio. But that is definitely not a film. So let us hear from the audience, participants. Yes, so the time is over now. Yes, so let us see how many of the people. What is the right answer? What is the right answer? Computer ji, zara bataiye. So cello show is the right answer. So obviously I didn't know anything about RRR. So I am pretty bad. For me, cello devas and cello show are also one and the same thing. Because if you have a day, then you will have to have a show also, or a show will follow on a day. But anyhow, Kashmir Files, I have heard something about Kashmir Files because it was in the newspapers. Unfortunately, I do read some newspapers. So for me, this was zero. If I would have been in your place, I would have scored zero in this. So importantly, the computer G will give us the answers, but the correct answer will not get the award. The correct answer with the person who gets it the fastest. So the fastest finger first, that person will get the award. So we will not see who is the fastest person in this because these are dummy questions. But yes, you can see there are many people who are like me. So that is the plus point. So there are many people who are like me because there are all types 1, 2, 3, 4. So maybe I'm not bad. If I again started doing my MD, so I will be as good as you probably. So good. I have not become very old. That means about 20 years later, also 25 years later. Well, anyhow, let us go to the second dummy question. That means there are responses from many candidates. So the question is, who is the current Chief Justice of India? Uday Umesh Lalit, Ranjan Gogoi, Sharad Arvind Bobde, and Nuthalalpati Venkat Ramanna. So the timer starts now. Yes, please start the timer. So you have 20 seconds, but you have to, even if you know the answer, you have to be very fast because somebody who presses the correct answer fastest will get the award. I am also poor. I know that the Chief Justice retired about a fortnight back, but I don't know who has succeeded him. So very good. So what is the correct answer, Computer Ji? Please enlighten me also. Uday Umesh Lalit, you Lalit. It is just like RRR for me. But anyhow, with due respect to the chair of Chief Justice, it is UUL. I will also remember. So yes, Ranjan Gogoi, I knew it was not there because he was there long time back. But other names are also as alien to me as number A. So Computer Ji, do we have the proportion of people who have got this right? I would have scored, maybe yes, there are 3 questions. That is why that is a problem. If you have 4 MCQs, then the probability of scoring 1 correct is after 1 out of 4. So they have kept only 3 so that I fail on all the 3. 2 I have failed. Third I will again check. Yes, the answer is many people know. So now that means that time is against me. My age is, now I am aging. So A is the correct answer and many of you have got it correct. So congratulations to those who have got it correct, but this is a dummy question. Don't expect rewards for it or this will not go counting towards your total score. So yes, Computer Ji, we will move to the third question. Let us see. Now this is also, Dash is newly appointed trustee of PM Cares Fund. Gautam Adani, Ratan Tata, Mukesh Ambani, Asim Premji. So timer starts now. These are very difficult questions for me.
So requesting to go slow.
Yes.
Dr. Anupam.
Yes, I heard it. I got
Dr.
it.
Anupam, yeah, I request you to go slow because now the timer there is 12 seconds in
Okay.
at the student's end.
Okay.
At the student's
Good.
end. Yeah, it is still 4 seconds. So
Okay.
so now it is 0 seconds there. So this much time lag is needed before you put in the answer.
Cheek. So Computer Ji, can we have the answers? Ratan Tata, very good. So yes, we know about Ratan Tata. He has been an entrepreneur and he is one businessman that we all look forward to because there is a lot of ethics that has been with him when he is doing business. And definitely through the ages, his father also, J.R.D. Tata and now Ratan Tata, they have been there at the helm of affairs and they have done, even in COVID, you must have understood that a lot was donated and he was one of the first persons to do it. So I am not bad. I also don't know the answer, but yes, there are many people like me who do not know the answers. So well, I think most of the attempt, the scorer will kindly let us know that yes, they are attempting correctly.
Yeah, 6-0.
Okay, that is wonderful. So now we move to the main session, and best of luck once again from all of us to the participants. So now we will move to the first question. Which one of the following treatments is ineffective in management of hyperthermia? Acetaminophen, ice packs in groins and axilla, IV cold saline, and bladder irrigation with cold saline. So you have 4 options. Your time begins now. And you have to, if you know the answer, put it correctly as fast as you can. 5, 4, yes, you are going. So time is running out now. So computer ji, can we have the correct answer? So the correct answer is A. Now I will just elaborate upon it. See, this is hyperthermia and not hyperpyrexia. And there is a difference between hyperpyrexia and hyperthermia. So in hyperpyrexia, whenever you have fever, the hypothalamic set point is reset at a higher level. And then NSAIDs or paracetamol or acetaminophen, they actually bring down the hypothalamic set point. But in hyperthermia, there is a problem in heat production. Either it is excess or there is less heat dissipation. So that mechanism of heat production is more or heat dissipation is less. So NSAIDs, the hypothalamic set point is not reset, and NSAIDs actually or acetaminophen or paracetamol is actually not indicated. So you have to use external or internal cooling measures whenever you are treating patients of hyperthermia. So this is important, and let us see how many of you got it right. So computer ji, aap elaborate karenge please. So many of you have got it right. Very good. So it is important. So acetaminophen is not to be used. Other things are part and parcel of external or internal cooling, and those mechanisms can be used. Now let us see who got the fastest finger first. Can you display the name, computer ji? Dr. Kanav Khanna. So congratulations, Dr. Kanav Khanna. You got it in 3 seconds. Very good. So you have prepared well for the quiz. I must say, acknowledge that, and congrats to you. At least you are now in the fray because you got at least one question wrong, right. So thank you. And computer ji, दूसरे question पे चलते हैं. Let us see. We move to the second question. This is, which one of the following patterns of fever is observed in enteric fever? Intermittent fever, continuous fever, Bell-Epstein fever, and relapsing fever. So you have 4 options, and your time begins now. Read the question carefully and try to answer it also. So your time is running out. Those who have attempted, well and good. Otherwise, you just finalize it. So, well, what is the correct answer, computer ji? Can we display it? So there are lot many options, and we do have misconceptions at times. But characteristically in enteric fever or typhoid, what we call it commonly, the characteristic pattern that has been described traditionally is continuous fever. So it is important that we understand what is these different types of fever. Continuous fever is fever which has a which remains throughout the day and has variation of less than 1 degree centigrade throughout the day. So it will continue to be there. Yes, with rampant use of NSAIDs and paracetamol, this typical pattern is not commonly seen. But yes, characteristically in enteric fever, it is continuous fever, and there is a specific pattern also. After continuous fever, it is a step ladder fashion. So that is very, very important. Intermittent fever is, yes, you have intervals of freedom. So you will have fever which touches the baseline. And relapsing fever is, you will have fever on some days and there will be a gap. You will not have fever on some days. And Bell-Epstein fever, That is a very common MCQ that comes. It is fever that is characteristically described with Hodgkin's lymphoma. So these are important things, and I have just discussed all the four because when you actually deal with MCQs, you should know all the choices. That will make you enrich your knowledge also, and you will be able to identify it because another MCQ could be based upon relapsing fever or palepsine fever. Well, computer ji, can we have the answer, correct answer? I mean the number of persons who got it right. So yes, quite a few significant percent, 50% have got it correct. But there are less than 50% people who have actually got it wrong also. But importantly, typhoid is very common and we should actually know what is the characteristic. And in fact, typhoid can present with septicemia, enteric fever can also have a varied manifestations involving all systems. Well, can you have the lucky winner for this question? The fastest finger first, Dr. Kanav Khanna again. Well done. And again, it is 3 seconds. So you are now leading in the forefront. Well, congratulations again, Dr. Kanav Khanna. So that is amazing. 2 questions on the trot and the fastest finger on both. So very good. Keep it up. Computer ji, can we move to the third question? Paget's sign or relative bradycardia may be seen in which one of the following clinical conditions? Rheumatic fever, streptococcal pneumonia, bubonic plague, COVID-19. So please read the question carefully and answer it as soon as the timer starts. So your time begins now. Time is running out. You don't have characteristic diseases out here mentioned in the choices, so that makes it a little tough. But yes, it is important for all of us to know the answer. Computer ji, can we go to the correct answer? COVID-19. Yes, very important. I think it is important for all of us to understand that COVID-19 was a new illness. We are dealing with it for the last 2.5 years. And importantly, you should understand relative bradycardia is also described with diseases like enteric fever and a whole lot of viral illnesses also. But important thing is that when COVID-19 came, we found that relative bradycardia, or what is also known as Paget's sign. So relative bradycardia does not mean you have bradycardia. It is not sinus bradycardia. Sinus bradycardia is a heart rate of less than 60 beats per minute. When you talk of relative bradycardia, it is the rise in pulse is not as rise as you ordinarily expect when the fever is there. So whenever temperature is high, you expect that the pulse rate will also rise. But in cases of relative bradycardia, or when we say Paget's sign is positive, the rise in pulse is less than as anticipated for the rise in temperature. So a patient who is having 102 degree Fahrenheit temperature may be having a pulse rate of about 80 or 90 beats per minute. That indicates the pulse should have been risen. Roughly it rises about 5 to 10 beats per minute with every degrees of temperature. So in that case, with 102 degree Fahrenheit, it should be roughly under 120. So this is important, but in this case, supposing it is 96, then that means this is relative bradycardia, and this is what is Paget's sign, and very characteristically seen with enteric fever and a whole lot of viral illnesses, and characteristically in COVID-19 also. So can we have the correct answer? How many people got it right? Oh, very good. People have 22% have got it right, and there was a little confusion about it. So unfortunately, yes, it was a tricky question, and it was actually intended to be a tricky question. So when you have the basket of MCQs, there will be some questions which will be very simple, some will be very tough also, and at times some will be a little confusing or misleading. So you have to be very careful. Let us see who got the fastest finger first. Computer ji, Dr. Vineet Goel. So very good. We have another contestant in the fray. So Dr. Khanna will have good competition now. So we have some people, and this is so this was a tricky question. The time taken to answer is 5 seconds. So people did spend a little time to answer this question. Very good. Let us move to the next question. Computer ji. Congrats, Dr. Vineet. The vaccine that is known to offer some protection against monkeypox is chickenpox vaccine, smallpox vaccine, BCG vaccine, and measles vaccine. So A, B, C, D, please select the correct choice and as early as possible. So your time begins now. Time is running out. Please select your choices. Monkeypox is another disease which is there, and we are facing the brunt of it, although there are not too many cases. So it is important. Computer ji, can we have the correct answer? Now there are a whole lot of choices here. So smallpox vaccine is the correct answer, and even BCG was actually considered to be effective against COVID-19. So there were trials which were there. Measles vaccines trials are also there. So all four choices could have been an option. Chickenpox and monkeypox are pox related. Smallpox and monkeypox again are pox related. So when you attempt an MCQ, you can get confused because of this. But remember, monkeypox and smallpox, the virus for both the illnesses, it belongs to the same genera. So monkeypox is closely related to smallpox. And in fact, chickenpox is herpes virus family. So it is a totally different virus. So you should always remember, although it is again pox related, but this is not a common pox. This is a misnomer, you may say. It is because of the eruptions that it is called pox, and it has nothing to do with relation. So remember, smallpox was eradicated long time back, about 50 years back, less than 50 years, 45 years back. And smallpox, actually, the lesions are centrifugal. In chickenpox, the lesions are centripetal. And again, in monkeypox, the lesions are centrifugal. So you have the hands and the feet, which are more involved rather than the trunk, in smallpox as well as monkeypox. And that is what is characteristic. Both these diseases they belong to the same family of viruses. Unlike chickenpox, which is a herpes virus illness, and BCG vaccine, measles vaccine. So because the same virus family, the protection with smallpox vaccine is considered to be there for monkeypox. And chickenpox is not the right answer. So let us see how many of us got it correct. Computer ji zara dikhaएं, please. Computer ji, can we have how many people got the answer correct? Computer ji नाराज हो गए हमसे. So yes, very good. Many people have got it correct. More than 50%, 55% have got it correct. So very good. Well done. So computer ji, can we have who got the fastest finger first? Dr. Jainin Jain. Very good. Congratulations, Dr. Jainin Jain. And he has taken 4 seconds. So everybody is just very close. And I must say the contest is becoming tougher and tougher now. So we have 4 questions and there are 3 competitors already in the fray. Well, best of luck to all the remaining ones also. I hope we have a new name every now and then, and that will be very helpful also, and it will be a very good contest. So can we go to the next question, computer ji? In the diagnosis of malaria, thick smear is done for identification of the species, determination of level of parasitemia, sensitivity testing, all of the above. So be careful while answering this question. Your time begins now. Well, these are very tricky questions. So your time ends now. So these are very tricky questions. I was saying, we all understand. We read it day in and day out when we are actually learning microbiology or in PSM also, and even in medicine also and pediatrics. But the problem is the distant we get from our MBBS days, the more difficult these questions linger on, because we are not doing it routinely. So those who do it routinely are able to answer it, but otherwise it is difficult. We tend to forget and we get confused. So the correct answer is you have two types, thick smear and thin smear. So I always remember it. Thick smear is identification of the parasite because you have thick. So you have more blood on the slide. So it will help you identify the parasite. So yes, computer जी ने कहा कि मैं आंसर गलत ना बता दूं तो उन्होंने मेरी हेल्प के लिए जल्दी बता दिया. Very good. So when you identify thick smear, you have lot of blood. So you will identify easily the parasite and you will be able to see the parasite. And if on a thin smear, you have less of blood, so you can see the details. So identification of the species is on a thin smear and the level of parastemia or identify whether a parasite exists or not is on a thick smear. So that is absolutely correct. Computer जी ने कह दिया correct तो correct ही है, उसमें कोई बात ही नहीं है. So let us see how so those who have gone for sensitivity testing and all of the above are actually wrong. So let us see how many of us got this wrong. All right. Computer ji madad karenge? Yes, very good. So there are people who know the answer and we are consistently touching the 50% mark. So at least 50% of us know the answer. So we are 4 right now visible also. So I think only 2 know answer. I don't know at times. Yes. So computer ji fastest finger kiska hai? Dr. Abhijit Sarkar. Oh. So now we have 5 questions and we have 4 competitors already in the fray. So this is going to be a very tough contest now. Well, congratulations, Dr. Abhijit Sarkar. We move to the next question. Question number 6. What is the primary monitoring investigation in dengue for management? Platelet count, hematocrit, total leukocyte count, hemoglobin. So we have 4 choices and your time begins now. The questions have been very intelligently planned, so be very careful while answering them. And I know it is very tough at times because you don't have second choice to correct it, your wrong answer. Well, your time ends now. And this is again a very tricky question. And at times it is, but it is a very important question because dengue is now virtually endemic and we have every 3rd, 4th year, we have a whole lot of cases across the length and breadth of the country. So computer ji, आप सही आंसर बताएंगे? नहीं तो फिर आप मेरी मदद करने आएंगे? Yes. So the answer is B, hematocrit. So I will just dwell into a little detail of it. For dengue, we all understand when we need to make a diagnosis, it is a non-specific fever unless until you have hemorrhagic manifestations. It is just a plain simple viral illness. And in a viral illness, when you have, there are a whole lot of viral illnesses. We have influenza, we have RSV, and we had COVID also. But when you have viral fever or a febrile undifferentiated fever with leukopenia and thrombocytopenia, then virtually you know that yes, this is dengue fever. And the fever will usually last for 3 to 5 days, at the most 7 days. This is characteristically what is dengue fever. But that helps you in diagnosis. But when you have to manage, it is the hematocrit which is very important. Hemoglobin can become low when you are actively bleeding, but hematocrit rises whenever the patient actually starts to have third space losses. And that is what actually is the cause of death in dengue patients. It is not hemorrhage. It is third space loss or intravascular leaks. So that is what actually have to be prevented. And that is the earliest sign in these patients is actually a narrow pulse pressure. The diastolic rises and the systolic starts to fall. And that is what is actually incipient shock, or you should consider it that the patient is going to be now deteriorating or the third space losses will start. So that is one sign we need to see. Patient will also have tachycardia and on a laboratory investigation, a rising hematocrit. Any patient who has a high hematocrit, that means that patient in the critical phase of the illness and you need to push in fluids. Push in fluids, if the patient can accept orally, give oral fluids also. Well, that is a point which we need to always understand and it has to be taken into account. So computer ji बताइए जरा कितने लोगों का सही आया? How many? Oh, so this is now we had only 2 choices. So hematocrit now this is good, very good. People know, and I think we will not keep this question next time because many people now understand that yes, they are on the right track. So maybe in another quiz we can have this question so that this 10% also goes off and we have 100% correct. Then we will be managing dengue in the right earnest, and I think we will be able to salvage patients also. So let us see who is the fastest finger first. Computer ji madad kare. Dr. Aditya Gupta. Now this is going to be very troublesome for all of us, and I think we will have to postpone the quiz at the end of it. There are so many contenders. If we don't have after the 6th question, we have 5 contenders. Dr. Sudarshan, आपसे मदद चाहिए होगी हमें end में.
Okay, okay.
Because
I'm
there are
here.
5 contenders already in 6
Yeah,
questions.
yeah.
By the end of 20, we don't know what will be there. So again, the time lag is very short. They are answering very fast in 2,
Yeah.
3, 4, 5 seconds.
Yeah.
And there are 5 contenders. Congrats, Dr. Aditya. But yes, you are making our life tougher. So anyhow, congratulations. We move to the next question. But now
Yeah.
I'm handing over the baton to Dr. Ramesh. He will carry you forward in this quiz. I will rest my voice.
Thank you, Dr. Anupam, for the teaching both the faculty who are on the board and the students who have been actively participating in this quiz. So let us move to the next question, which is question number 7 of this quiz. Computer ji, please, question number 7. So the question is, which of the following do not represent leishmaniasis infection? Your choices are choice A, Kala Azar, choice B, Malta fever, choice C, Baghdad boil, and choice D is dum-dum fever. And your time starts now. So the time is over. And can we have the correct answer first? Okay, so Malta fever does not represent leishmaniasis infection. Again, leishmaniasis infection, as you all know, Kala Azar by the name, it is endemic in eastern part of the country and with some spillovers which we sometimes see in the central part of Delhi and other parts of the North India. And the disease has been endemic and still being continued despite availability of drugs like amphotericin and liposomal amphotericin B. So what about the other choices? Like Kala Azar, I think most of you have, most of you know that it is represented as a leishmaniasis. So Baghdad boil as the name suggests that the capital of Iraq, which is Baghdad, so it had witnessed war for so many years, and there was a time in the year 2004 when suddenly 300 soldiers were affected by leishmaniasis. Probably they were not using any repellents or mosquito nets, and since it was a huge casualty to the army, so it came as a Baghdad boil. Then the dum-dum fever, it is named after the Scottish doctor who was William Leishman, and the dum-dum is a place which is in Calcutta. So they have, just for the namesake, they have this fever is also known as dum-dum fever, leishmaniasis. Malta fever is not leishmaniasis, it is brucellosis. It's a zoonotic disease, and it also has some others name like rock fever, Banks disease, Mediterranean fever. So the correct answer is Malta fever. So can we have how many students have really got it right? So 61% of the students were right, and around 40% still were confused about this. So that's nice to learn. Okay, can we show Computer ji who is the winner of this question? So Dr. Abhijit Sarkar. Okay, so Dr. Abhijit, many congratulations. So probably this is your second question, which is correct, and you are actively competing with Dr. Kanak, who also had got 2 questions right. So many congratulations to you, and we can have next question, Computer ji. So the gold standard for treatment of brucellosis in adults is choice number A. Is it ceftriaxone and rifampicin, or is it streptomycin and doxycycline? Choice C, is it gentamicin and ciprofloxacin? Choice D, is it trimethoprim, sulfamethoxazole, and rifampicin. And your time starts now. So the time is over, and I'm sure if okay, let us computer ji first show the right answer to the students. So the right answer is streptomycin and doxycycline. So this question will be interesting to know how many of you are able to answer this question, because if you look at the choices are very close. The choice A has a ceftriaxone and rifampicin. Choice B has got an aminoglycoside and a doxycycline. The choice C again has a aminoglycoside and a fluoroquinolone. And choice D has trimethoprim, sulfamethoxazine, and rifampicin. If you have read the question carefully, probably you would have been able to answer it. The standard of treatment for brucellosis in adults. So there is a difference between the treatment in adults and the children less than 8 years of age. And this is from Harrison. So the correct answer is streptomycin and doxycycline. And if there is an allergy to streptomycin and doxycycline, then there comes the other options, like you can use a combination of gentamicin and ciprofloxacin, but the choice is streptomycin and doxycycline. In children less than 8 years, the drug of choice will be trimethoprim, sulfamethoxazine, and rifampicin. So let us see how many of you are able to answer this question correctly. Computer ji, can we see the number of students who have answered it? Okay, so 70%. So this is a surprise for me. If you are able to answer this question correctly, it is really very heartening to know this. And who is the winner of this question? Dr. Aditi. So we have one more contestant who is entering this race to go to Bangalore, Dr. Manjula. So this competition is going to be really very interesting. So congratulations, Dr. Aditi. And we hope there are still many questions and you will be able to answer them and come in the forefront. So Computer ji, can we have the next question? So the next question is, undulant fever is described in malaria. Choice B, scrub typhus. Choice C, leptospirosis. Choice D, brucellosis. And your time starts now. So the time is over. So Computer ji, can we have the right answer? The correct answer is brucellosis. The question is not very difficult. The point here of repeatedly highlighting about brucellosis in this quiz is that it is now not a very uncommon disease. So we must be able to diagnose this disease, and first of all, we should be able to suspect this disease. The disease is it's an infectious disease which is caused by a Brucella species, and the organism is an aerobic intracellular Coccobacilli. As I already told you that it is also known by the name of Gibraltar fever, Crimean fever, goat fever, and what is more important is that people who are dealing with the poultry or the milk or the goat or the cow, so we must suspect someone who is coming to you with fever for prolonged duration, along with lymphadenopathy and organomegaly. And the closest differential will be tuberculosis in some cases. And in those cases, a careful history taken from the patient will give you the vital clue. Because the CT findings again in the abdomen will not be very specific, and then it may mimic tuberculosis only. So Computer ji, Can we know how many of students have answered this correctly? So again, many of you are aware of this question. Question was not very difficult. And the idea here was to make you aware about brucellosis. So 60% of the students have answered it correctly. And who is the winner of this question? So Dr. Aditi. Okay. So Dr. Aditi has taken less than 2 seconds to answer this question. Many, many congratulations, Dr. Aditi. So can we move to the next question, Computer Ji? So the next question is that following features are suggestive of poor prognosis in severe falciparum malaria, except, is it hyperglycemia? Is it leukocytosis? Choice C, is it hyperparasitemia? Choice D, is it severe anemia? So your time starts now. Okay, so your time is up. Again, malaria, as Dr. Anupam told in the initial quiz, that malaria is a very common disease, which is, of course, prevalent all over the India, and simultaneously dengue, malaria, and of course with intermittent COVID. So this is disturbing throughout the India. But now complicated malaria or severe malaria is not only limited to falciparum malaria, as you all know. Vivax is equally causing a lot many complications in as far as malaria is concerned. But by definition, if you have read this question carefully, the poor prognosis in severe malaria are if the parasites are too much, like hyperparasitemia. Computer ji, can we have the right answer? Yeah. So hyperglycemia is the correct answer. That means it is not a poor prognostic marker. The poor prognostic marker are hyperparasitemia, leukocytosis, and severe anemia. What happens in malaria is the hypoglycemia. It is because of the decreased gluconeogenesis. And earlier, when the quinine was very commonly used, it was one of the major cause of hypoglycemia in patients. And vomiting, decreased appetite by the patient, they all lead to hypoglycemia. And it is one of the important things that residents and doctors should be aware that when we treat malaria, the sugar levels may go down. So we have to be watchful for them. So can we have the breakup of how many students could answer this question correctly, Computer Ji? So of course, the number is now more than 60%. So it's good that you are aware that hyperglycemia is not a poor prognostic marker. And who is the winner of this question? Computer Ji, who is the winner of this question? So Dr. Kanav Khanna. Okay. Dr. Kanav Khanna. Very, very, very congratulations, Dr. Kanav. You have answered this question correctly. So can we have the next question, Computer Ji? So the next question is treatment of leptospirosis in penicillin allergic patients is choice A, gentamicin, choice B, chloramphenicol, choice C, erythromycin, and choice D, sulfa drugs. So your time starts now. Okay, the time is over. Again, the leptospirosis is not an uncommon disease now. Mostly it was limited to the southern part of the India during monsoons in the earlier days. But nowadays we all can see the patients of leptospirosis in the medical wards. The patient typically will have a fever along with jaundice and sometimes with neurological problems, and a history of exposure to the sewers or maybe to the urine of the rats is the etiology behind the for developing leptospirosis. And the treatment is very important because a single dose of an antibiotic will save the patient. And if the treatment is delayed, then the disease will be fatal. So, Computer ji, can we have the right answer first? So, in the patients who are not penicillin allergic, so the drug of choice is penicillin or ceftriaxone. But here the problem is, if the patient is allergic to penicillin, then which of these drugs to be used? And this drug will sometimes be also useful in pregnant patients when they develop leptospirosis. So erythromycin is the right choice in penicillin allergic patients for treating leptospirosis. Computer ji, are we ready with the results? How many students have been able to answer this question correctly? So again, 52% of the students are able to answer this question correctly. So this was a little tricky question. Of course, the straightforward question would have been that what is a drug of choice for treating leptospirosis? But there are situations when the patient is allergic to ceftriaxone and it becomes difficult and you need an alternative. And erythromycin is one such drug which can be easily given to the patients, and it can have the same remarkable effects as when we use ceftriaxone. So who is the lucky winner of this question? Dr. Anmol. Okay, so we have another competitor in the list. Dr. Anmol, well, many congratulations for answering this question correctly. And you have been able to answer this question very quickly. Probably it must be some experience of in your medical wards that you are aware of this question, the answer to this question. Thank you, Dr. Anmol. Congratulations. Computer ji, can we have the next question? Increase in rate of fluid infusion in dengue hemorrhagic fever is driven by A, 20% rise in hematocrit, B, 10% rise in hematocrit, C, platelet count below 10,000, D, platelet count below 20,000. And your time starts now. So the time is over. Computer ji, can we have the right answer? So 20% rise in hematocrit. Again, this is a common question, but a very tricky question. As Dr. Anupam already gave you and explained you that when you're treating dengue, especially dengue hemorrhagic fever or dengue shock syndrome, it is primarily governed by, the treatment is governed by the hematocrit and not the platelets. So platelets you give when the patient is actively bleeding in the form of epistaxis or hematemesis or internal bleeding or hematochezia. But the amount of fluid which has to be given is driven by the rise in hematocrit. So any 20% rise in the baseline hematocrit, it will reflect that the patient is having a third space volume loss, and that becomes an indication to intensify the rate by which you give or infuse fluids. And probably you may have to use sometimes colloids instead of crystalloids when such a rapid rise in hematocrit occurs. And the same formula you use when you are watching the response to your treatment. The fall in hematocrit with the improvement in the clinical condition of the patient will be equally important in judging how much fluid you have to decrease as the patient is responding. So this is a clinical bedside question, and in day-to-day practice, dengue is this type of knowledge will help you in better treating the patients. So Computer ji, can we have the breakup who all are be able to answer this question? So 60% of the students have not able to answer this question correctly. Again, I said that this was a little tricky question. Of course, the platelet is almost ruled out, as we can see from the results. Around say 7 to 8% of the students are still confused at hematocrit or between hematocrit and platelet. Probably this question will clear their doubts. Only 31% of the students could answer this question correctly. So many congratulations to all those who could answer this. And who is the winner of this question? Who could do it very fast? So Dr. Akash Malhotra. Many congratulations, Dr. Akash, to you for answering this question correctly and in a timely manner. So, Computer ji, can we move to the next question? So the next question on your screen is, which of the following statements is true about use of fosfomycin in urinary tract infections? A, it is given intravenously for 10 days. B, it is given orally dosing in BD dosing with meals. It is given as a sachet to be dissolved in milk and given empty stomach. Or choice D, it is given orally at bedtime with water and after urination. And your time starts now. Okay, the time is over. So can we have the correct answer, Computer ji? So the correct answer, it is given orally at bedtime with water after urination. So I'm sure almost 60 to 70% will be knowing about this, and most of you may have some confusions. Urinary tract infections, you all know, are uncomplicated, complicated, and catheter associated. And we all deal and treat such patients. Because of the rampant use of and irrational use of antibiotics, again, there is a lot of resistance which has come in for treating UTIs. And you must all be seeing that the commonly used drugs like nitrofurantoin and fluoroquinones, they are mostly resistant as far as the treatment of UTIs is concerned. Now, fosfomycin is a drug which probably I think people from medicine, they use it less reluctantly, at least at our center. But it is again a drug which can be used orally instead of intravenously. And but some precautions have to be taken when this drug has to be given, that it is given at bedtime and with water. It's a sachet or granules which has to be dissolved in water in a glass, and it can be then taken by the patient at bedtime after urination. And in complicated UTIs, you have to give this drug for some more time rather than 1 day. But in uncomplicated UTIs, only a single dose will be sufficient. And the precaution which has to be taken is that, again, it has not to be taken with meals. So either the patient has to take it in the early morning or 2 hours after meal or at the bedtime, which is more preferable. So the choices were close enough. And Computer ji, can we see how many of the students were able to answer this question correctly? So, again, the choices, the responses from the students itself shows that there is a lot of confusion, and probably as we are not using it, that's why we have got a confusion in answering this question. 55% of the students were not sure and they marked it incorrectly, and 40% of students could answer it correctly. And who is the lucky winner for this particular question, Computer ji? Dr. Naveen Chhaba. Congratulations, Dr. Naveen. So this quiz is going to be really very, very interesting. So we have now probably half of the competitors, half of the winners are now there. Like if we have probably done somewhere about 13 or 14 questions, and there are more than 7 or 8 winners, which I can see. So many congratulations, Dr. Naveen. And I think Dr. Shubha Lakshmi, you can take over from me after this.
Yeah, sure. Thank you, Dr. Ramesh. And we can move to the next question if Computer G is ready with it. Okay, so we have seen gold standard test for diagnosis of scrub typhus is indirect immune fluorescence, ELISA, blood culture, wheel flex test. Your time starts now. So time is over, I think, already over. And this scrub typhus is also very common, or now it has been like few years that we are able to diagnose it very frequently, seeing more cases. So we should be aware of the diagnosis also, how to make it. So Computer G, can we have the answer? Correct answer? Okay, so indirect immune fluorescence. So what about the other, that ELISA, wheel flex, and blood culture? This scrub typhus, as I told, it is also known as bush typhus. Mainly the patient present with to us with fever, body ache, rashes sometimes, and specific rash is present, which is known as Ishar. So if it is present, it is like diagnosis of scrub typhus is almost confirmed. But if it is not, because it is not always seen, so if it is not, then we have to, or otherwise also we have to go for these investigational tests. So ELISA, it is one of the very sensitive tests and a specific test, but still it is not it is not the gold standard. Why? Just because it requires a special pairing test. Pairing is required for sampling, so it is not the gold standard. Blood culture, again, it is not always that we can find the organism in it, and it also takes time and expertise of the person who is doing it. Wheel flex, it was initially used as one of the tests for diagnosis, but because of cross reactivity and low specificity and sensitivity, it is not used now as a gold standard. So indirect immune fluorescence, it is used, and it requires it is used because of its higher specificity and sensitivity in diagnosing this disease. So Computer G, if we are ready with the percentage of students that have answered correctly. Okay, so nice. It is 38% almost, but still confusion is there. And as I told, this scrub typhus is a tropical infection, and we should be knowing more about this. So we need to a bit more this thing with this question or with this topic. So Computer G, who has answered it correctly? Can we know the name? Okay, Lovepreet Kamboj. So again, one more competitor who has entered the list. So many congratulations, Dr. Lovepreet. The answer has been documented in 4 seconds. So that is very great, very good. So, okay, now moving on to the next question. Computer G, are we ready with the next question? Okay. So in cyclical neutropenia, fever returns every how many days? 3 days, 9 days, 21 days, or 28 days. Your time starts now. So time is almost over. This neutropenia term we are very well aware of, but what is this cyclical neutropenia? So this we will see. Computer G, can we have the correct answer first? Okay, so 21 days. So what is this cyclical neutropenia? It is a rare hematological disorder or condition which is characterized by regular fluctuation of this neutropenia or neutrophil levels, which is seen in every 21 days. So once neutropenia is there, patient will have, or it will manifest as fever in the patient. So it is like question is like fever returns every 21 days because of this neutropenia only. Fever, oral ulcer, gingivitis, tonsillitis, pharyngitis, and dermatological infection or manifestation are also seen in this this cyclical neutropenia. Lymph node may be palpable, and this is how it is known as cyclical, because it returns in every 21 days. It is cyclical, and this fluctuation of neutrophil levels lead to this neutropenia. So Computer Ji, do we have the participant percentage who have answered this question correctly? Very nice. So 60% of us are aware of this cyclical neutropenia. This is very nice. Who has answered it quickly? Computer Ji, can we have the name, please? Anni Abhishek Sharma. Very well done, Dr. Anni Abhishek. And you have answered it in 3 seconds. Very nice. So this cyclical neutropenia we should be aware of, because if we are not, then we can misdiagnose, or this can just go as a FUO. So we should be aware of this condition. Can we have the next question, Computer Ji? Okay. So Covishield vaccine for COVID-19 is a killed vaccine, subunit vaccine, adenovectored vaccine, or live attenuated vaccine. Your time starts now. Okay, so time is almost over, and we are all aware of this COVID infection because last 2 years we are all seeing this. So Computer Ji, first we will have the correct answer, and then we will discuss. Okay, so adenovectored vaccine. So Covishield was one of the vaccine which was available in India, and many of us have got vaccinated with this Covishield vaccine. But there are many other type of vaccine which were available in India as well as in other countries. So adenovector vaccine, it was a recombinant vaccine, and almost 72% efficacy was seen against COVID-19, and it contains genetically modified organism. Other vaccines like subunit vaccine, it was a protein subunit vaccine used for this COVID-19, and killed vaccine. Again, this was not the Covishield, it was not a killed vaccine. And live attenuated, definitely not. It was not, because it was adenovector vaccine. Other vaccines like Covaxin and Moderna, these were all available with us for this COVID-19 infection. So Computer Ji, can we have the correct percentage of patient students? Okay, so 39% of us have answered it correctly. So that means we are all aware of this COVID, and we have read and we have learned a lot from this, but still confusion is there. This should not be that much. So Computer Ji, who has answered it correctly, can we know? Suman Saurabh. So very nice, but he has taken 5 seconds. So it was not so easy, I think. But yes, congratulations, Dr. Suman Saurabh. Now moving on to the next question. Computer Ji, can we have the next question? Yes. So humanity has but 3 great enemies: fever, famine, and war. Of these by war, the greatest by war, the most terrible is fever. Who said this? John Hopkins, William Osler, Hippocrates, or Alexander Fleming? Your time starts now. Okay, so time is over now. So this is a very common saying, or we have heard this line many times. So Computer Ji, first tell who has, what is the correct answer for this question? Okay, so William Osler. Who was he? He was a Canadian physician, one of the 4 founding profession of John Hopkins Hospital. So he was the founder member, founder funding member of this John Hopkins Hospital. He has been described as a father of modern medicine and one of the greatest diagnostician ever to be wielded with a stethoscope. So this he has given this line that fever, famine, and war, of these by the far the greatest, by far the most terrible is fever. John Hopkins, he was another. He was there in the funded hospital that William Osler has funded, and he was a Quaker entrepreneur and in the University of Maryland. Hippocrates, we all know, he has given the Hippocratic oath, and he is known for that. Alexander Fleming, he is known for the discovery of penicillin, that and the group of drug which we are using now also. So, Computer Ji, can we have the percentage of student who has given the correct answer?
I think 100%. I think most. Okay.
Oh, no, no.
So 53% of them has given this as an answer. So, but yes, we should be knowing about these names of the person who are attached or who was linked with the medicine. Computer Ji, who has given the correct answer quickly? Vijay Kumar Jat. So congratulations, Dr. Vijay. He has answered in 3 seconds. Answer this question in 3 seconds. So that is great. Congratulations. And moving on to the next question. Computer Ji, if we are ready with the next question. Yes. So in a patient with FUO, the detection of a classical neurological finding, that is oculomesticatory myorrhythmia, is pathognomic of which infection? Q fever, Whipple's disease, non-tuberculous mycobacteria, or leprosy? Your time starts now. Okay, so now the time is over. This oculomesticatory myorrhythmia, this is pathognomic of this disease. So let's see what is the correct answer. Computer Ji, Whipple's disease. Okay, so what is this Whipple's disease, or what is this oculomesticatory myorrhythmia? So Whipple's disease is a systemic, it is a rare systemic bacterial infection that affects the joint as well as the gastrointestinal tract. And this may cause this pathognomic oculomesticatory myorrhythmia. What is it? It is actually the eye movement disturbance and myorrhythmia, that is rapid repetitive movement of the muscle of the face, and it is together referred to as oculomesticatory myorrhythmia. So if it is present, it is pathognomic of this Whipple's disease. Other are Q fever, non-tuberculous mycobacterium, and leprosy, we are all aware of. So this finding is specific to this Whipple's disease. So Computer Ji, can we have the percentage of students that have answered it correctly? So if we are not able to detect the fever or detect the cause of the fever, but still this finding is there, then we can go for Whipple's disease. So 57% of the students have answered it correctly. That is very nice. But yes, other have few confusion in it. So this pathognomic feature should be known because it is diagnostic, almost diagnostic of this disease. So Computer Ji, can we know the person who has answered this question correctly in few fraction of seconds? Aditi Tongar. So Aditi has answered it in 6 seconds. So that is good. Congratulations, Dr. Aditi. And that you have read this question before also, or this topic before, that is good. So moving on to the next question. Computer Ji, do we have the next question? Yes. The number of days recommended by WHO to observe a dog for sign of rabies is 10 days, 15 days, 7 days, or 5 days. Your time starts now. So the time is over now. So rabies, it is one of the commonest this infection or bite we see, and dog bite is very common. Very now and then we are hearing about the news of this dog bite, or the people are terrified by this dogs here and there. So we should be knowing about this because we have to observe the dog as well. So Computer Ji, can we have the correct answer first? So 10 days. So as we are we were just discussing that dogs, if they bite or if they lick, there are grades of infection. We grade it as category 1, category 2, category 3 of rabies. If they have licked the non-breached surface of the skin, then it is category 1. If breached surface is licked, it is category 2. And if it is the scratch mark or bite mark is there with this breach of the mucosa, then it is category 3. And if this infection is left untreated, can be fatal also. So when to observe, till when we have to observe this dog. So the infection, a symptom of this rabies can be seen up to 10 days, can appear in a dog within 10 days or up to 10 days. But yes, it can vary up till month also, because non-infectious, or you can say non-symptomatic period is also there, which can be seen in this. And at that time, what happens, the virus is in latent stage and dog behaves very normally. So it can be missed also if this is in no symptom phase. And other symptoms are like abnormal behavior of the dog, that is lethargy, sometimes aggressive behavior, or sometimes the dog is very lethargic, and licking of the wound is also very commonly seen and observed and has been reported also. So let us see.
Ma'am, Professor Sudarshan sir is there. He is the WHO expert on rabies. So if we can add, so that students will be benefited.
Yes, definitely.
From my 15 years of working for rabies as an expert in WHO Geneva, what I would like to say is this is a well accepted thing, and it is a standard that in rabies endemic countries like India, let us be India focused, if there is a dog bite and if the dog is observable, so we start the post-exposure treatment, but observe the dog for signs of rabies. And if by 10 days, if there are no signs, then we can stop the treatment. That is the series of vaccination. Usually 3 doses would have been taken, and this will be considered as a pre-exposure vaccination for future. So that is advantage. And 28th September is World Rabies Day. So that is a few days from now. And it is the death anniversary of Louis Pasteur. And the theme for this year's World Rabies Day is One Health and Zero Death. So we should not have dog-mediated, dog-transmitted human rabies deaths by 2030. So this is a WHO goal, and India also is a signatory, and we are also working for achieving this goal by 2030. That is, no human rabies deaths subsequent to a dog bite by 2030. I think I have taken sufficient time. It is back to the quiz master and to the Computer Ji. Thank you, madam. Thank you.
Thank you very much, sir, for enlightening us.
Thank you.
So this was very information required and will definitely benefit the student as well. So Computer Ji, can we have the student percentage that has been answered correctly? So 68%, I think 69%. Yeah. So that is good. That is good that our students are also aware that we have to observe the dog for 10 days. And others have some confusion, but yes, the sir has already cleared our confusion that 10 days has to be observed, and the dog has to be observed for 10 days. So let us see who has answered it quickly. Computer Ji, can we have the name? So Dr. Vineet Goel in 4 seconds. Very nice. Congratulations, Dr. Vineet. And I think rabies is a very important topic to be known and read, and we should be aware of each and every aspect of this topic. So congratulations. Now moving on to the next question. Computer Ji, can we move to the next question?
Last question.
Yes, sir. Last question.
Hopefully, sir, if no tie break.
So, which of the following readings qualify for elevated temperature? Temperature in evening around 5 p.m., that is more than 37.0 degrees centigrade. Temperature in morning around 5 a.m., 37.6 degrees centigrade. Temperature anytime during the day more than 37.2 degrees centigrade. And temperature in afternoon around 1 p.m., that more than 36.5 degrees centigrade. Your time starts now. Okay, so time is over. So again, to the basic, fever and temperature. This is very important topic, and we should be knowing the variation, the normalcy, when we will call it normal, when it is elevated. So computer ji, can we have the correct answer? Okay, so here is the correct answer. Temperature in the morning around 5 a.m. is 37.6 degrees centigrade. So there is variation of about 1 degree Fahrenheit in the morning and the evening, that we should be aware about. And when it is called abnormal, when it is normal, that is also important. So when we call it normal is 37 degrees centigrade or 98.6 degree Fahrenheit. This we consider to be normal. Any variation with this is abnormal. Usually the oral temperature is considered to be more accurate because it is nearer to the core temperature. So that should be taken and preferred to be taken. Otherwise, auxiliary in wards and otherwise auxiliary temperature is also used, but it should be used accordingly. So computer ji, can we have the percentage of students they have answered the question correctly? Okay, so 72% have answered it correctly. That is good because this is the basic topic. Fever quiz with fever question is a must. So that is very nice. So let us see who has answered it correctly within time or in a quick time. So Naveen Chhaba, Dr. Naveen Chhaba has answered this question in 4 seconds. So congratulations to Dr. Naveen. So Manjula madam, can we have
Yeah,
move on to
ma'am.
this? Yeah, please take this thing.
Yeah. Thank you so much, ma'am. We require our computer IT team will be consolidating the thing. And Sir Panda, sir, if sir is around, if he wants to make any quick comments before we go and announce the results. Sir, Jayant Kumar, sir, is there? Panda, sir? Anupam, sir, any last minutes or before
Dr. Panda is there on 2 devices. Probably he must be having problem in logging in. But anyhow, so with blessings of Dr. Sudarshan, sir, I would just say that yes, it has been a very interesting quiz because never I have witnessed that out of 20 questions, there would be 15 competitors or 14 competitors. So that is really very strange. And I must compliment Dr. Ramesh, Dr. Ghanshyam and Dr. Shubh Lakshmi for making it a very interesting questionnaire because the questions in the quiz, they range not only from hyperthermia to fever as the last question, definition of fever, and also there were a variety of infections, not only clinical signs like rash, eschar and jaundice, and but also apart from that, there were a whole lot of diseases. So anybody who has actually read different topics or all tropical diseases and different aspects of fever would only be able to answer. And probably, I think there is a message for all the competitors that you have probably, most of you have probably read some topics very well. That is why you have been able to answer in 3, 4, 5 seconds, because it is really very strange that all the questions have been answered in 3, 4, 5 seconds only. There were no questions which took you very long. So you are master ace of one subject or one topic, but to have a, I would say, wholesome or composite view of all the diseases is actually very, 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 very essential in a country like India, which is as diverse as Dr. Ramesh was saying, east you have Kala-Azar, then you have leptospirosis, which is down south, then you have scrub typhus, which was having pockets some years back. and now you have scrub typhus in the sub-Himalayan, northeast belt also. And again, you have diseases like dengue, which when I did my MBBS, they were probably not so rampant. And in last 25 to 30 years, now they are there. And every third year, fourth year, you know that you will have a big outbreak, which will be there over and above the baseline. So the quiz has been, I would say, it is a very interesting quiz, and it is actually, that is why probably there are not many scorers. I don't think anybody would score more than 3 or 4 out of 20 questions. So that is actually the problem. But yes, I think that message is very important, that all the students that have participated, they actually have to go through tropical infections, because mind you, these cases do not come to you in examinations, because you get a neuro case, you get a gastro case, you get a this cardiovascular, respiratory, connective tissue disorder, as Dr. Suresh was there yesterday. You get collagen vascular disorders. You get all kinds of cases. You don't get tropical infections because they have fever, which we consider ordinary. But remember, Dr. Shubhlakshmi said, William Osler said, it is the most terrible when you are not able to diagnose these patients. And these fever patients are the bread and butter of any general practitioner, any physician. Because fever, everybody will have. There is not a single person who will not have fever. And everybody who has fever, most of them will seek advice, unless until it remits with paracetamol or dolo of Dr. Manjula. But still, that is the problem, because so I would again request, seeing this message, actually, I have a bad habit of analyzing everything. So I feel that we should spend more time on tropical diseases and infections, because anywhere you go, today only I would give you an example. I'm sorry. We have time, Dr. Manjula?
Yes, sir. You please go ahead.
So today only somebody was asking me for yellow fever vaccine. We don't see yellow fever in India. We don't actually deal with it. But yes, when you travel abroad, especially to African countries, you need to get a vaccination. And then what are the indications? What are the contraindications? When you should get it done? The time of travel before you leave the airport or you fly off. All these things are important. Similarly, we had a resident who has gone to Antarctica for 6 months. You have to get vaccinations. You have to get certifications. All those things are important. Every year at Delhi, we face people go for Amarnath Yatra. So there are so many problems. People go for Hajj, especially in another part, even in southern part, there are areas where you have international airports. You have all kinds of vaccinations, all kinds of diseases, and even diseases which affect travelers. Traveler diarrhea is a small chapter in every book. But the thing is, when you actually manage Hajj areas where you have Hajj prayers, Kumbh Melas, these conglomerations will continue, and tropical disease will also continue. It is prevention which is actually very important, and knowledge about all these is very, very important. Otherwise, you cannot prevent. If you do not have the knowledge that what actually is required, then you will not be able to manage these things. And once or the other, we will land to trouble. Well, I think I have spoken enough. Thank you so much, Dr. Sudarshan, sir. Dr. Manjula, please.
Yeah. So, madam, do we have time?
Yes, sir. You can make your comments.
Yeah. So when the results are ready, you can tell me. Now the results are ready.
Before results, I would like to talk about case presentation competition. You can complete, sir. Then I will.
No, not much actually. It is in continuation of what I was telling about rabies. From my 3 decades of experience, what I have noticed is generally there is a confusion between dog bite and human rabies. Dog bite is an injury and is a clinical condition, whereas human rabies is a disease, and both have different ICD codes. And so dog bite is the beginning of, if not treated properly, post-exposure treatment or post-bite treatment, first aid and vaccine and immunoglobulin, rabies immunoglobulin or monoclonal antibodies. Then there will be a viral entry inside a nerve, and then through the exoplasm it will reach the brain, and there is no cure. So the post-exposure prophylaxis is life-saving. And now with this end rabies by 2030, India is also a signatory to the WHO goal, and now it is planned to strengthen post-exposure prophylaxis in all the government hospitals, because majority of the dog bite victims are poor. They don't get the vaccine and immunoglobulin. This is one aspect. And the other one is actually mass dog vaccination. I will limit it to humans. And the new arsenal has come for managing dog bites. Earlier, it was rabies immunoglobulin, human and equine. Now, rabies monoclonal antibodies have become available. Both are produced in India and they're available in all the major cities. And one can also now use monoclonal antibodies, which are cheaper than HRIG, and no test dose is required. And any small bleeding wound is a category 3 exposure, and we should treat it with a rabies immunoglobulin or rabies monoclonal antibody. And vaccine is for everybody, all exposed persons, category 2 and 3. So with this, I stop, and it is back to Dr. Manjula. Yes, madam. Yeah, please.
Thank you so much, sir. Thanks all the panelists, Sudarshan sir, Anupam sir, Ramesh Agarwal sir, and Lakshmi, Pankte sir, and Panda sir. So thanks for wonderful session we had. Before we are going to announce, I just want to make one more announcement. Fever Foundation will be conducting another scientific event for all the postgraduate, which is PG poster competition, which we had last year. So this year also. So we are starting, you will be receiving the mail and the link will be open. This is basically an electronic form you need to submit. So this will be in preparation to our FEFCON 2021, which will be on 5th and 6th November 2026. So it will be in the virtual poster presentation, though the conference will be hybrid form, but the poster presentation will be in the virtual form. Next slide, please. And the last date for submission of your posters are 16th October. So the link will be made available to you. We have your email ID, it will be come to you also. Next slide. I just quickly tell you some of the rules and the guidelines for submitting your poster. The poster is acceptable only in the electronic poster form, and it should be in the PowerPoint presentation only, and no photograph or hard copy of the poster or photograph of the hard copy of the printed poster is not acceptable. It should be submitted only in a prescribed PPT one single slide format, which will be available to you in the link, which will be sent to you during registration. And you can either submit it as a case study or original research paper. And our scientific committee is going to screen all the submitted applications, and then they're going to pick top 10, and you will be made to make presentation to our scientific committee. Only the first author will be allowed to present the paper. And I'm reiterating, poster to be submitted as per the template only. And also please note that the title of the word should be limited to 15 only. So you cannot have a very long titles. And along with a single slide PPT, you are requested to submit an article in a Word form, which is about maximum of 500 words. So article should be in the Word format, and you need to follow the style of JAPI, the Official Journal of Association of Physicians of India. And all acceptance of the poster is at the discretion of our scientific committee, and the decision is final and it is binding. And during the conference, all the selected posters will be on the virtual hall, and it will be available for all the participants and the registered delegates of the conference to view it. So we will be also sending to all your departments all the information. So looking forward to get some interesting cases and original paper presentation. Thank you very much, and congratulations to the winners. I don't know, they are going to tell us now. And more than that, I feel all of you are winners who have participated, and really it was wonderful having you all. Right, sir. Over to you, sir, Anupam Prakash, to announce the winners if it is ready.
Well, yes, let us hear from Computer G and the scorer. Result of North Zone, yes, it is ready. So hold with bated breath and let us congratulate the winners. The winners are North Zone, Dr. Aditi Tongar and Dr. Kanav Khanna. Very good. So congratulations. Dr. Aditi Tongar from MMSI, MSR, Mullana, Ambala, and Dr. Kanav Khanna, PGMR, Chandigarh. So heartiest congratulations. So you have to book your tickets for Bengaluru. and Dr. Manjula will assist you to be there. You both have to work as a team, as Dr.
Yes,
Manjula
sir.
said, and you will be representing North Zone. So congratulations for today and best wishes for the final quiz that you will have at Bangalore.
Yes, sir.
So thank you and congratulations. So luckily, as I already said, you have don't have many competitors because everybody scored. And I think, as Dr. Manjula said, participation is important. And many of you actually could get the right answers, at least one or two, and that is really very great. But all the best to the winners, and to all those who participated, thanks and congrats for participation. Well, thank you and congratulations once again.
Yeah.
Dr. Ramesh, Dr. Shubhlakshmi, you want to say anything? Otherwise, we hand over to Dr. Manjula.
So just
Yes,
one thing, we will book the
congratulations
tickets,
to the
sir. They will not.
I know. That is why I said you
So
contact Dr. Manjula.
Fever Foundation winners, Fever Foundation will be contact you. Our Fever Foundation team will be contacting you and facilitate your all the travel to Bangalore and your stay. And secondly, we will also be sharing each other, Aditi and Kanna, you will be sharing each other contacts so that you can discuss and form a very strong team, because you will be competing with other zones for the final competition.
I will sound you a warning also, because you will find the same faces of Dr. Ramesh, Dr. Shubhlakshmi and Dr. Ghansham as quiz masters there also. So you be very, because Praveen is very kind, he will not only book your tickets, he will book the quiz masters tickets also. So you be very careful. Recognize them and be very careful from them.
Chalo. All the best to all of you. Thanks
Yes,
very
all
much.
the best.
Thank you, Sudarshan sir.
Thank you. Thank you. Thank you,
everyone.
everybody.
And
Thank you,
thank you, sir,
everyone.
for
Thank you.
staying till
Thank
the
you.
end. And Dr. Ghansham also.
Thank
Thank
you.
you.
Thank
With
you.
the permission of all of
Yeah.
the judges, and can we
Yeah.
stop the live
Yeah.
recording?
Yeah.
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 Yes, sir.